uh, lifestyle medicine, and I board certified last year. I practice in Toledo, Ohio, and I'm practicing completely lifestyle medicine. I'm a family physician and geriatric specialist. I've been in academics, and now I have my own concierge, connected care, and trying to do lifestyle medicine with technology also added with Carium app and all that. And my goal in India is to disrupt primary care through technological, and API is actually helping me. Love to connect with you, and I want to thank Dr. Kaushik Reddy for introducing us to you. You are our icon for lifestyle medicine. You have laid the highway for us, and now it's our job to kind of join you and kind of increase the speed and be a, we look forward to all the guidance, and Dr. Boja Reddy is here. We just want to thank you.
Well, thank you.
Thank you, Murthy. Good morning, everyone. So we apologize for the little bit of a technical glitch in the last minute, but again, very good morning. This is Dr. Boja Reddy Karipalli, and I'm a practicing family physician and API delegate from US. And then welcome to the third day of our Global Health Summit 2020, organized by AAPI, American Association of Physicians of Indian Origin. And as a tradition, we do have this annual. So this is the 15th Global Health Summit here in Hyderabad, India, and we welcome you. And as you might have noticed, past 2 days have been pretty busy and hectic, and we have amazing speakers and experts from various specialties and so forth, including the medical students. We had exciting the Jeopardy or the medical quiz for the medical students, and the research poster presentation as well, which is actually we just launched last year at the Global Health Summit, and this year was a tremendous success as well, followed by Women's Forum and our CEO Forum. So it was pretty busy past 2 days. And what makes today special is Dr. Anupama Gotamukla, so president of our API and then API leadership, actually, this year's theme being prevention. Prevention is better than cure. That's the motto and the theme for this Global Health Summit. And under that theme, we've been working with lots of healthcare professionals and then the leadership, and we worked on an array of agenda, and they wanted to introduce, work towards promoting these the principles of lifestyle medicine, not just in India, but in general. So this is going to be historic because API now decided to collaborate with our ISLM, Indian Society of Lifestyle Medicine, and bringing the leadership from both parties, American College of Lifestyle Medicine and ISLM, together for the first time as a consortium to bridge that gap, and just like in other areas, to make the difference in the healthcare system here in India, the knowledge transfer and the technology transfer, and adapt the most latest and advanced approaches in handling the chronic lifestyle diseases. So having said that, thanks to Dr. Anupama and API leadership for dedicating this morning for this lifestyle medicine module. So we wanted to bring some thoughts and then expert suggestions from the thought leaders. So we invited a great panel of speakers from both United States and India to share their views and then help us actually move forward on this mission. As we know, you might not be able to change the world overnight, but you should be able to change your corner of the world. And again, we say, dream big, start small, but begin now. And I believe today is that now. And then through this API and ISLM consortium, we're taking that first step to draw our roadmap to make a difference in the lives of Indians and then beyond. So it's my pleasure. Again, this is Dr. Karipalli. I'm a practicing family physician in part of the university health system for past 15 years in San Antonio, Texas. And then we have amazing panel of speakers. The first speaker, it's my pleasure and privilege to introduce the first speaker for this morning, Dr. Neil Bernard. He's a well-known speaker, author, and researcher in the field of lifestyle medicine. And through his more than 2 decades of research and guidance, has been helping us move forward, especially working in collaboration with the American College of Lifestyle Medicine. He's a faculty at the George Washington University in Washington, D.C. And he authored multiple books under the lifestyle medicine principles and so forth. So let's welcome. So ladies and gentlemen, put your hands together to welcome Dr. Neil Bernard to paint a picture on the past, present, and future of the lifestyle medicine at a global stage. Dr. Bernard.
Well, thank you very much. I want to thank you in particular, and thank all the organizers for allowing me to spend some time with you. I also want to thank Kaushik Reddy, a wonderful cardiologist and a good friend and a pioneer also in the movement of lifestyle medicine. So thank you for letting me be part of this very, very important conference. If you don't mind, I'd like to share my screen and share a few thoughts with you. The future of lifestyle medicine. Let me go back to perhaps where we were a couple of decades ago. A person might develop a condition, heart disease, diabetes, weight problems, hypertension. They would see the doctor, and the doctor might recognize the fact that lifestyle, particularly food, plays a role in this condition. So they would say, well, a few diet changes might help. Well, here in America, the way that was played out was have more chicken. Take the skin off your chicken. Have more fish. Have more chicken. And more fish. And more chicken. And more fish. And eventually, the patient, having done all these things, goes back to the doctor who says, well, the diet didn't really lower your cholesterol very much. So I think you'll need a statin. And in fact, your blood sugar is still high too. Let's talk about insulin. And about your blood pressure. Wait a minute, stop. Dr. Dean Ornish, who's a name that's familiar to all of you, a pioneer in the world of heart health, said, wait, let's take another look at this. Maybe there's a reason that the diet changes that doctors had been proposing didn't really work very well, because the failure of diet therapies to lead to impressive results meant that they were really relegated to the sides, and pharmacology became medical, really the key medical tradition at that point. But what Ornish said is, wait, let's look at animal products. The middle column here is the cholesterol content of animal products. On the right, you see the saturated fat content of a wide variety of animal products. And as you know, saturated fat in the diet stimulates the body to produce cholesterol. Well, they all have quite a lot, including that fish. In fact, in Chinook salmon, there's more saturated fat than there is in a lot of animal products. But in contrast, plant products don't have cholesterol and they have almost no saturated fat. So what Dr. Ornish said was, let's see if we can do better. He brought in people who had already moderate to severe heart disease, so much that they had narrowed arteries on angiography. He brought them into the lifestyle heart trial and asked them to do 4 things. Number 1, vegetarian foods. No cholesterol. Not much animal fat, really. Okay, it's vegetarian. Half-hour walk every day, manage stress, which is why he didn't do the study in Washington, D.C. or in Mumbai, and avoid tobacco. That was the whole program. No drugs, no surgery, just simple diet and lifestyle changes. And the results were impressive. But so was the intervention. The foods that people were eating were delicious. There was no portion limit, no calorie limit. They ate wonderful foods, and the total cholesterol dropped 24%. LDL cholesterol dropped 37%. Your average person lost 10 kilograms over the course of a year. And when the participants had angiography after 12 months, you could see clear signs of reversal of coronary lesions in 82% of participants. Now, to show what this looks like, this is a slide that I got from my good friend, Dr. Caldwell Esselstyn at the Cleveland Clinic. This is a narrowed artery in a surgeon. And the surgeon was not a candidate for either statins or stenting. His only choice, get the cholesterol and animal fat out of his diet. He did a totally vegan diet. And after 32 months, this is his coronary artery. If you're having trouble seeing it, you can drag the little photo strip out of the way or minimize it, because I want you to see this. That artery looks like it's recovered. It's become a normal coronary artery, and this gives us a lesson. The body can heal. You don't doubt this when it comes to cutting your skin. I don't care how old you are. That cut will heal. You don't doubt this when it comes to a fractured leg. That fracture will heal. A Band-Aid doesn't heal the skin, and neither does a cast. They simply allow the healing processes that are intrinsic to the body to take over. And what Dr. Ornish showed us is that the arteries can heal. So the question is, how far can we take this? Many doctors thought, well, maybe this will work, but no one would adhere to it. It's much too strict. So Dr. Ornish actually invited me to come to California and interview all of the participants in his trial to see how they actually felt about it. And what we discovered was this. The people in the vegetarian group did grumble a bit. They said, you know, I've got to learn some new ways of eating, not eating steak and chicken anymore at all. How long did it take me to get used to it? Maybe 4 or 5 weeks. Are you going to stick with it? Absolutely. My chest pain is gone. I feel better than I felt in years. I'm slim, I'm trim, I'm energetic. I wouldn't give this diet up for anything. The control group grumbled as well. They were eating chicken and fish and chicken and fish and chicken and fish, and nothing was getting better. They still had chest pain. They were still on medications. And what we realized is that not only is a healthy diet possible, it's acceptable. Patients want it. And when the patient wants it and the patient heals, the doctor's job is the most wonderful job that you could ever imagine, because you're working in collaboration with your patients. My research team then said, let's apply this to other conditions. We did studies on weight issues and many other things. And I want to share with you the results of our diabetes trial funded by the National Institutes of Health starting in 2003. We tested a conventional diet versus a plant-based diet. And the conventional diet you're familiar with. Limit calories to lose weight. Keep carbohydrates steady. Avoid the bad fats like saturated fats and trans fats. But the plant-based diet said no animal products, minimize oils, favor low glycemic index foods like beans and vegetables, green vegetables, instead of white bread. But you'll notice there wasn't any limit on calories. There wasn't any limit on carbohydrate. But the results, when we look at A1C, were dramatic. The red line is the conventional diet, and they did well. They dropped their A1C by about 0.4, but the blue line is the vegan diet, and they dropped by 3 times more, 1.2 absolute percentage points. No limits on carbohydrate, no limits on calories. It is old-fashioned and out of date and not evidence-based to try to help patients to lose weight by just cutting calories or telling them to avoid carbohydrate. What we want to do instead is make a qualitative shift, eliminating the animal products that cause the problem in the first place, keeping oils low, and helping the patients to eat healthier foods. Vance is one of our first research participants in this trial. He came into the study, he lost 60 pounds over about a year on this plant-based diet. He stopped his diabetes medications. His A1C dropped from 9.5 to 5.3. When I got his results, I have to say this challenged what I knew about diabetes. At the George Washington University School of Medicine, where I was trained, I was taught, like all medical students, that diabetes is a one-way street. Once you've got diabetes, you'll always have diabetes. And it turned out that here was a man who had had diabetes for 4 or 5 years before joining our research trial. He was now on no medications, eating unlimited carbohydrate with an absolutely normal A1C. And we learned not only can your skin and your bones heal, not only can your arteries heal, but there's something about the body more broadly that type 2 diabetes can heal as well. Well, let me share with you what that is. This is a muscle cell, and muscles are powered by glucose. And so the glucose needs to get into the muscle cell in order to power it, but it can't. The glucose builds up around the outside of the cell. It cannot penetrate the cell membrane until I have a key. And that key is insulin. And the insulin key attaches to a receptor on the surface of that muscle cell. When the insulin key attaches, it signals channels to open up to allow glucose to enter the cell. Great. Everything's working fine. The glucose is getting out of the blood into the cell. So what could ever go wrong? What goes wrong is these are the foods that I'm eating. Fish fat, chicken fat, oil. And those fats, yep, there's a lot of fat in these foods. Those fats build up inside the cell. Now, we doctors hate words like fat. It has only one syllable. So we'll call it intramyocellular lipid, but it's fat inside a muscle cell. What can I do about it? I better do something, because as long as it's there, my insulin key won't work anymore. The insulin still attaches to the surface of the cell, but the cell does not respond. Glucose cannot enter the cell. But what if I go on a diet that doesn't have animal products in it? There's no animal fat left. What if I keep oils very low? The fat starts to dissipate. It goes away. And as that fat dissipates, insulin resistance is replaced by insulin sensitivity. And now insulin can work again, just like in Vance's body. The glucose that's been building up in the blood starts coming down because it's going into the cell. Maybe my diabetes has been healed. But what's going on with this? Our good friends and colleagues, Kit Peterson, Jerry Schulman at Yale University, brought in young, healthy people, 26 of them, and they gave them a glucose tolerance test, 75 grams of syrup, to see what happens to their blood sugar. Some of them turned out to be insulin sensitive, normal. Some were insulin resistant. Who were they? Well, they were young, late 20s, thin. They weren't heavy. They didn't have diabetes. They had absolutely normal A1C levels. But let's go into our MR laboratory. Through magnetic resonance spectroscopy, I can look inside their muscle cells, and I can see something shocking. On this graph, every dot is a person. These are insulin-sensitive individuals, and this is the amount of intramyocellular lipid in the insulin-sensitive, that is the normal participants. These are the people who are insulin resistant. As you can see, it's true. The fat has built up inside their muscle cells. And that's what's leading to the insulin resistance. In turn, that's causing their mitochondrial activity to be suppressed. These are the normal subjects. These are the insulin resistant subjects. What am I saying? I'm saying that at the age of 17, 18, 19, you could do MR spectroscopy in just about any school in the United States and many places in India. And what you would find is that the fat content is building up inside their muscles, inside their liver cells. They are becoming insulin resistant. They won't have diabetes for another 15 years, 20 years. The disease process has started, and it started with food choices. They developed a taste for cheese and fried foods and chicken and fish. And their body found a way to extract the fat from these foods and pack it into their muscles, pack into their livers. And that led to insulin resistance, and ultimately will lead to diabetes, and ultimately lead to their death 10 to 15 years prematurely. Lifestyle medicine means thinking of food in a totally new way, as a way that we can treat conditions that we never really thought of before. This is Chicago, Illinois. The Chicago Health and Aging Project looked not at heart disease, or weight problems or diabetes. They looked at Alzheimer's disease, and they added up the amount of saturated fat, bad fat, that people in Chicago ate. Some of them ate relatively little, 13 grams a day. Some of them ate about twice as much, 25 grams a day. What they discovered was that Alzheimer's risk was well over double in the group eating the most saturated fat. This was published almost 20 years ago, and other researchers have since confirmed that the more saturated fat a person eats, the higher the risk of Alzheimer's. The more trans fats people eat, the higher their risk of Alzheimer's disease. And there are many factors that can prevent it. Vegetables, fruits, foods rich in vitamin E, lacing up your sneakers and going for a run. By changing our lifestyle, especially our diet, especially getting the animal products out, bringing the plant products in, we have control that we didn't have before. Doctors have tools they didn't have before, and patients have power they didn't have before, which they appreciate enormously. Our research team recently did studies on menopausal symptoms. Why? Because at age 50, 52, 55, some women are being burned up by hot flashes. They're sitting in a board of directors meeting and suddenly they're overwhelmed by heat. It happens in the middle of the night as well. They go to the doctor and the doctor says, well, let me give you some hormone replacement therapy. The patient takes the prescription to the drugstore where she learns that it's associated with breast cancer, endometrial cancer, stroke, myocardial infarction, and the possibility of dementia. She doesn't really want it, but her symptoms don't go away. She takes the drug, and after a few years, the doctor says, we have to stop this. This is too dangerous for you to continue. The patient says, but doctor, you prescribed this drug for me. The doctor says, yes, but it'll cause breast cancer in you. 1 in every 25 women who takes this for 10 years and more or more will get breast cancer that I have caused. We can't continue. The patient says, what kind of medicine is this? Our research team did something different. We first looked around the world and we discovered that menopausal symptoms aren't the same in different places. Rare in Japan historically, increased in Japan as it westernized, and we found that certain diet changes might be effective. We brought in premenopausal women, half of them did a diet, half of them stayed on the control group, and what we found was that the diet change reduced moderate to severe hot flashes by 84%. It was a simple plant-based diet, minimizing oils, adding soybeans every day to take advantage of their isoflavones, no medicines at all. But lifestyle medicine, which I'm just touching on, is more important now than ever. Not only because we have heart disease, not only because we have cancer, not only because we have diabetes and weight problems and menstrual symptoms and all kinds of things that are subject to control by diet, but we have many other things too. But there's one that's in the newspaper every day, and that's COVID-19. These are global deaths. 8,303 people died today of COVID-19. It's been a roller coaster ride in India, just like everywhere else. And what does the future hold? We don't really know. But there's one thing that we do know, that this is not a democratic disease. There are certain people who get it and tend to do very well. There are others who get it and they die. As soon as the pandemic emerged in China, it was very clear that the higher your body weight, the more likely you were to have severe COVID. And it wasn't just weight, it was also diabetes. Those individuals who had diabetes had a higher risk of COVID mortality. And if you had diabetes in good control, you could greatly reduce the likelihood of dying if you were infected. So researchers then said, wait, you can't control necessarily whether that virus will enter your body. We'll do our best by social distancing, mask wearing, and so forth. But once it's in you, what happens? Researchers about 6 months ago published this study. They looked at individuals, healthcare workers in 6 different countries, and what they found is that those whose diets were more plant-based had a 73% reduced risk of severe COVID. But those who followed a low carbohydrate, fad diet, the kind of diet that says don't eat apples, don't eat fruits, don't eat starchy vegetables, had a 48% increased risk of severe COVID. Around the same time that this study came out, another one came out from the COVID symptom study. This study began almost as soon as the pandemic began. More than 500,000 people were tracking their health with a cell phone app and also recording what they ate, more than 500,000 of them. And what they found was that about 30-some thousand of them developed COVID. Well, how did this relate to what they were eating? Well, it turned out that if you were following a more plant-based diet, your likelihood of getting any kind of COVID was cut by about 9%. Statistically significant, but not super impressive. But then when you look at severe COVID, those who were on a more plant-based diet had a 41% reduction in the risk. So this confirms the finding of the healthcare workers study, is that a healthy diet doesn't just help you with heart disease and cancer and weight problems and diabetes and so many other things. It has what we might call an immune boosting effect that helps us against even COVID-19. The latest shift on this, and I will finish with this, is vaccines. There's a huge movement, and understandably so, to get people vaccinated to prevent the spread of this condition. But researchers looked at 86 healthcare workers who got 2 Pfizer doses, and they measured their waist circumference. They assessed their smoking behavior, their blood pressure, and their cholesterol. And what they found was that if you look at waist circumference, the further out on the right, that's the higher your waist circumference. And what we're going to look at is your antibody response to the Pfizer vaccine, which is the y-axis. And here's what they found. The wider your waist circumference, the poorer your immune response. You get the vaccine, but nothing happens. This was not a surprise. We knew exactly the same thing from influenza vaccines. And then smokers, that's the black box. Smokers don't do as well. You can vaccinate them, they have a poorer response. People who are hypertensive, that's the black box in the middle, also have a poorer response. Those with dyslipidemia, I'm talking about a high LDL, much poorer response. What are we saying? What we're saying is that if we follow a healthy diet, it won't just help us to heal from heart disease, from the other conditions, but it also makes us stronger in the face of unexpected threats. So all of you who are with me now as this program continues today, we're taking into hand incredible power that makes, frankly, our job easier, much more rewarding because we're using tools that work. But the most important thing is that we're giving our patients tools that they can use for their health and that they can in turn pass along to their children, having the confidence that they can not only be in good health themselves, but they're helping the next generation and future generations to be able to safeguard their health in ways we could only have dreamed of back when we were in medical school. Thanks for letting me share this time with you today.
Thank you, Dr. Bernard. That's awesome. So it's always inspiring to listen to you, actually. And thank you very much for bringing the most recent data, especially pertinent to COVID. And that's pretty reassuring to see the power of plant-based diet and then the kind of difference it can make in the response to your vaccines and to the disease in general. But before we transition to the next talk, let's see if we have any questions from the audience. Please.
Dr. Bernard, thank you for the wonderful talk. What are your thoughts on the ketogenic diet, on the reversal of the chronic conditions? Thank you.
Thank you for asking that question. The ketogenic diet has been an off-again, on-again fad that tells people that they got their diabetes or their weight problems from eating carbohydrate. And it is true that if a person stops eating carbohydrate, they'll lose weight and their blood sugar will fall. That's because carbohydrates are 50 to 60% of what everybody eats. So if you throw out all of the apples and all of the bananas and all of the potatoes and all of the rice and all of the beans and all of the noodles, if you throw away 50 or 60% of what you eat, you know what will happen? You'll lose weight. Your blood sugar will fall because those are the sources of sugar. But then you get a blood test and you notice that your LDL went up. And that's because as you were leaving out the carbohydrates, you were tucking into dairy products and meat products. And so you're a bit worse off. And in fact, you're eating all of the foods that cancer experts say we should be avoiding. So there are many ways to lose weight and many ways to tackle diabetes. The ketogenic diet is the worst of the lot. It's appealing to people because if they follow it for a very short period of time, they see results. When they follow it over a long period of time, they often get frustrated, and it ends up being a very harmful diet, I'm sorry to say. So I would encourage people to think of keto as one of the many four-letter words we want to avoid.
Hi, Dr. Bernard. Good morning.
Good morning.
About this plant-based diet, this is out there forever, we Indian people are eating plant-based diet for probably 2,000 years. But still we have the highest diabetes, cholesterol, everything. And still we die. So can we do some kind of study in India and figure out is this real or fake or what?
You certainly can, and this is already happening now. There are many, many people in India who have been doing this exact diet. And what you said is right. When we look at Indian traditions, I have to say, these are beautiful traditions where the simple treasures of nature, lentils, spinach, potatoes, are transformed into the most wonderful meals a person could ever imagine. And for me, as a child growing up in North Dakota, I had no idea of the beauty that foods really could have until my first trip to India many years ago. However, my Indian friends have told me about a couple of trends that have eroded the beauty of the Indian diet. First is dairy products. Now, there is a big tradition, obviously, that many people defend, of including milk and cheese, paneer and ghee in the diet, as if this is somehow a respectful and natural thing. I'm sorry to conclude that we're actually harming ourselves and frankly, harming the cows by taking their milk and putting it into our bodies rather than leaving them to have it for the purposes that nature provided it for. When we consume dairy products, the dairy fat, which is largely saturated fat, ends up in our cells, just like any other kind of fat, and leads to insulin resistance. The second problem beyond dairy inclusion is the use of oils. Yes, vegetable oils are much better than animal fats, but they're still oils, they're still high in calories. And over time, more and more oil has come in, more and more dairy has come in. And in recent years, I'm seeing Pizza Hut and other Western chains all around India too. And is telling me, meat is coming in unprecedented ways. In fact, there are young people who, if they're asked, are you a vegetarian or non-vegetarian, will proudly declare, I'm a modern non-vegetarian. I sometimes think their great-grandparents might be upset if they heard them say that. If we can move to the fundamentals of the diet, which are four things: vegetables, fruits, whole grains, and beans, or the bean group, the beans, peas, lentils. Set aside, obviously, the meat, the dairy, and the fried foods. India's health will be the best health in the world because we have the most strong and wonderful culinary traditions in India compared with anywhere else in the world.
Thank you, Bernard.
Thank you.
Dr. Bernard. Yeah, so that was an awesome question, actually, Dr. Sintha. So thanks for that, elaborating on that, Dr.
One last question. Dr. Bernard, thank you so much for getting this diet for Indian population, especially Indian subcontinent. This is Dr. Anupama again. You answered the question before I was about to ask this question, like Indians, the vegetarians of India, who don't eat meat, they eat plenty of dairy products. So that's what my question is. We eat a lot of dairy products like yogurt, milk, and a lot of desserts made out of milk products. We eat a high quantity of that. And Indian pickles are loaded with oil, which they float in oil actually. So that's the diet of India, as you said, like preventing those dairy plus vegetarian what we eat, I think makes a difference for. So we need a lentil revolution or some kind of a revolution, anti-dairy and lentil revolution in India, probably. Thank you.
Thank you very much for raising this point. You know, I think we have to also remember that the people who are raising dairy products, and frankly, the people who are raising meat products, these are good people. These are honest people. They're doing what they thought was a helpful thing. But when we look beyond the surface of it, we see things that can be shocking. I know what I'm talking about. My father grew up in the meat industry, as did his father, as did my uncles and my cousins, and I personally drove animals to slaughter. When we look a little bit behind this door, we see some things that are troubling. The way we get a glass of milk in North Dakota, where I grew up, it's not very much different from what happens somewhere else. That the animals are impregnated, then their calves are taken away so that we can take the milk. And if they're male calves, they're often killed here in the United States, and in India, it's done in a more subtle way so that people can disavow it. And then we end up harming our health in the same way as we do a bit of disrespect to the animals. If we rethink that a little bit, we can have better health and treat the animals with more compassion.
Dr. Ravi Bhattacharya has a question again.
Yeah. Yes, just I came in, I already learned some of the wonderful stuff. In our culture, they always said the good diet is, in Sanskrit, hita and mita. You said already moderation. What you like, if you eat in moderation, may be the best diet. You know, she said about dairy products, but they had some of the southern states, they load with carbohydrate more than anything else. Thank you.
Yes, thank you very much.
Dr. Bernard, again, this is Murthy, and I just want to kind of ask you a specific question regarding chronic kidney disease and plant-based diet, the data and what happens. We have a few nephrologists here. Thank you.
Yes, it's a terrific question, and it's obviously a big clinical challenge. When people have chronic kidney disease, there are two culprits that every nephrologist is very aware of and that we look at as being behind much of this. One is hypertension, the other is diabetes. The nephrons are fragile, microscopic tissues that don't do very well when the blood pressure or blood sugar go too high. So earlier in my talk, I was describing how a plant-based diet can bring down blood sugar. It does that decisively. And if we're on a healthy plant-based diet, we can prevent much of the attack on the kidneys. The same is true with the effect of the diet on blood pressure. A plant-based diet brings down blood pressure quite decisively as well. When a person has a measure of kidney function loss, whatever the cause, the very best thing they can do to protect what remaining kidney tissue they have is to avoid animal products completely. In the Nurses' Health study done at Harvard University, researchers tracked what determined the further loss of kidney function in people who had some kidney damage. And the leading predictor was animal protein. The more animal protein people eat, the more the nephrons die. So when your patient comes in with elevated creatinine, you want, if they are still eating animal products, get them off them completely. Now, this becomes much more complicated when a person has completely lost their kidney function. At that point, they're losing protein like crazy. So you're going to be working upstream to make sure that you get adequate protein in them. But even at that point, there's no need for animal-based proteins. You can do this with plant proteins, and certainly should, because those patients are also at huge risk for cardiovascular complications as well. So this is a time when we want to use a plant-based diet. We also want to have an excellent dietitian working with you and working with the patient and the patient's family to help them to negotiate the diet changes.
We have a question from Dr. Neil.
Hi, this is Dr. Gupta. I had a question about what diet would you, do you have any studies which correlate to slow progression of dementia or prevents dementia?
Earlier, what a great question, because when you make a list of all the things you don't want to ever have, dementia is at the top of the list of things you don't want, because when you lose your memory, you've lost everything. The Alzheimer's studies that we have seen, and this probably applies for related dementias as well, they do seem to show a preventive effect, meaning the incidence of the Alzheimer's can, we believe, according to the best evidence we have, be greatly reduced by avoiding saturated fat to the extent you can, avoiding trans fats, having vitamin E rich foods in the diet, vegetables and fruits in the diet, avoiding excess metals like iron and copper and probably aluminum. That's a good recipe, but that's prevention. And the question then is, well, what if a person has some dementia already? What we are seeing is that individuals who have mild cognitive dysfunction, your ability to retain words and names is impaired. Those people will seem to improve with the diet change. And also researchers at the University of Illinois found that exercise can help those people too. The regimen they used was a 40-minute brisk walk 3 times a week over a year's time. They showed not only better recall, but you could actually show that the hippocampus was actually, the shrinkage of the hippocampus was actually reversed to a degree. So there's something to be said for diet changes and exercise. But these are in people with very mild dementia. As the disease process goes further, the brain cells die. And so I'm convinced that in the same way as myocardial infarction, you're never going to get that particular chunk of muscle cells to come back to life once it's been killed by ischemia. The same is going to be true of the brain.
Thank you, Dr. Gupta. That was a wonderful question, actually. Maybe Dr. Bernard, maybe you can just share some observations. If, as we know, don't we call Alzheimer's a type 3 diabetes now, potentially? And Dr. Dean Ornish, who actually proved the reversal of diabetes, through his program. And I know we know that he's working on the Alzheimer's as the next project. Maybe you can kind of share some observations or notes from that.
I'll let Dr. Ornish share his findings with you, and I am just like you. I'm on the edge of my seat and very eager to see what this medical genius is doing now. But I think really behind the question is a wonderful point, which is we used to think that the brain was one thing and the heart was something else. That if you had a stroke, that was one kind of dementia, but if you had Alzheimer's, that's completely different. But we're kind of coming full circle where we're realizing that these two interact a great deal. That in fact, it may well be that the reason why a high saturated fat intake is associated with Alzheimer's could well be something as inelegant as the fact that saturated fat elevates cholesterol levels. So we're now seeing this interaction, but it is more complicated than that because we're seeing insulin's action in the brain being under study and maybe perhaps playing a role here as well. There's a lot left to be learned, but the residue of fairly complex science is a fairly simple message saying that what's good for the heart is good for the brain. So we avoid the animal products, we exercise, throw out the cigarettes if we haven't done that already, and that will certainly protect the coronary arteries, hopefully protect the brain too.
I just have a last comment to that question. The Finland study that was done in 2,800 people with lifestyle measures and decline in the rate of cognition, and the Alzheimer's Association has partnered, and they've started 2 worldwide collaborative studies. I'm sure you've heard of that. The US Finger study and the US Pointer study. So it's a worldwide collaboration from the Alzheimer's Association trying to address the 6 pillars of lifestyle medicine to actually reverse. And I'm sure from Loma Linda University, Dr. Dean Sherzai also has created a neuron program. And I had a conversation with him about the neuron program, and he wrote a book called Alzheimer's Solutions. It kind of talks about the 6 pillars and how you can actually decline. I mean, he claims that mild and even MCI can be completely kind of reversed through lifestyle approach to care. I'm sure you've heard of that.
I think it's true that when people have tipped into mild dementia, that there is an element of reversibility. So I didn't want my comments suggesting that there is a point beyond which we're not going to improve. I didn't want that to mean that in the early stages of this disease, there isn't something that can be done. There is. And some of the work that has come out of Scandinavia has even led us to another really quite stunning thing, which was that lifestyle can be helpful even in the face of a rather poor hand genetically. You're dealt your hand. You've got the ApoE epsilon 4 allele. You got it. You're homozygous. You got it from mom and dad, and you think I'm condemned. I'm going to have Alzheimer's disease. Well, maybe so. But what the researchers found in their studies is that when you look at the development of mild cognitive impairment in these individuals, those people who avoid saturated fat pretty scrupulously have a dramatic reduction, maybe an 80% reduction in the risk of mild cognitive impairment, even if they are at genetic risk. So our bodies aren't perfect. I mean, you can be on a really great diet, and you can still you can succumb to problems, and genes sometimes do play a terrible role in our health issues. But for the most part, the genes are not dictators giving orders. For the most part, they're committees making suggestions, and sometimes you can argue with them.
Thank you, Dr. Bernard, for taking all those questions. Well, actually, that shows how much energy we have in the room listening to all those questions and the discussion. But yeah, so we just want to conclude that with one last question. If you can make a quick comment on the future. In other words, what kind of barriers are we seeing to adapt these plant-based diet or the principles of lifestyle medicine in general, Dr. Bernard?
I think there are a few things that will happen, and they're already happening now, and it's very exciting. The first, though, is more research on how these things are applied. I continue to be struck by the fact that lifestyle medicine, particularly diet, influences not just cardiovascular disease and metabolic disease, but also so many hormonal conditions, inflammatory conditions, neurological conditions, and we want to vigorously continue to explore these in human beings, so that we can learn their applications, also their limitations, and how to apply them in the best way. Then, those of us who are involved in teaching and those are people who are involved in medical school and in residencies have to insist that doctors learn these things. To this day, I'm sorry to tell you that a patient who comes into a cardiologist's office, if the patient had not heard of Lipitor, that would be scandalous. But if the patient if the doctor had never heard of Lipitor, that would be scandalous. But if the doctor had never heard of Dean Ornish, nobody would care. Incompetence remains the standard of practice in medicine when it comes to lifestyle medicine, and that really needs to change. Finally, we need collaborations. Many medical offices don't have a dietitian on staff or one to refer to. But when a condition is caused by food, a treatment that relates to food has got to be part of it as well. So we need a partnership in the same way as an orthopedic surgeon works with physical therapists. Internists need to work hand in hand with dietitians. We need to work as a team. And we need to not just send the patient out and wish them good luck. We need to have them come back next week, or at least get in touch by phone because they had a problem. They had a wedding to go to where they ate all the wrong things, or they were on a travel where things were challenging for them too. These are real issues that are simple to solve, but you need a little bit of help. So with more research, more education and learning, and more support with the patient that's given by the team of caregivers, I think we can really revolutionize medicine.
Thank you, Dr. Bernard. Really, we can't thank you enough, actually, for taking your personal time out of your busy schedule, and especially coming live, this late evening. It's, I believe it's 10:30 for you there, p.m. In your local time. We really appreciate bringing all the new data and the wisdom, and I'm sure that sparked some new thoughts and ideas to move forward. Thank you very much.
It's very kind of you to allow me to share this time with you. Thank you so much. Thank you.
Have a good night. Thank you. All right. Well, let me take a pleasure to introduce our next speaker. He's a good friend to all the API colleagues and Indian Society of Lifestyle Medicine fraternity, and he's actually a faculty on the ISLM team as well. Dr. Kaushik Reddy. He is an interventional cardiologist by profession, and he's the chief of the ICU and the interventional cardiology team department at the Veterans Affairs Institution, South Florida. And he's working hard. He's working hard to work with VA and the Department of Defense, which happens to be the largest national healthcare system in the United States, to introduce and then to adapt these the principles of lifestyle medicine. And through his work in the past few years, he's sitting on the data. Actually, we're waiting for his publications to come out. So he's joining us live from Florida, and he's the co-chair of the cardiology interest group at American College of Lifestyle Medicine, and he's the current treasurer of the American College of Lifestyle Medicine. Ladies and gentlemen, let's welcome Dr. Kaushik Reddy.
Thank you, Murthy, and thank you for the organizers, and also with a deep sense of gratitude, thanks to Dr. Bernard and PCRM. And it's a tough act to follow after a legend like Dr. Neil Bernard. Hope my presentation is of some value to the audience. Again, thanks for the kind words of introduction. One minor correction. I am no longer the treasurer at ACLM. I served for 2 years, and my term just finished a couple of months ago. But I'm very actively involved with various other components of the college, which is near and dear to me. And that, again, this presentation for both for professionals and non-professionals is for purely, educational purposes only. This is not a medical advice. And I also just want to make sure that this is not forming of any professional doctor-patient or a colleague relationship. And as you heard during the introduction, I am a public servant here in the US. I am 100% employed by the United States Federal Department of Veteran Affairs. I do not have any conflicts of interest of any sort, except to get this word out to my local community here in the greater Tampa area and also in the state of Florida. I run a nonprofit organization to just labor of love, if you want to call it. On weekends and weekday evenings, I just go out, meet with restaurants, meet with public schools, meet with local community, religious organizations to get the word so they don't end up on my cardiac cath lab table. That's the only conflict of interest, if you want to call it, that I have. So I'm an interventionalist or an interventional cardiologist, meaning that most of my training, most of my career, most of my even today's work is spent in the deep, dark dungeons of a lead-shielded cardiac cath lab. So what am I doing here? Asking people to do things that literally cuts volume to my work. So what am I actually doing here? So to kind of this is a little bit dated. It's about a few years old, but at the request of American College of Lifestyle Medicine, I wrote a narrative essay about my own personal transition into how did an interventional cardiologist come to be, making a personal, professional, and a passionate plea to himself, his colleagues, his trainees, his own family, and now to as many people as I possibly can, to not meet me in the cardiac cath lab. So I titled it, I Have a Carrot and a Stent, You Pick. I am now transitioned into wearing that on my jacket. I have it on my scrubs. And hopefully one day I will put a book together with the title. So, but a bottom line question, I usually start with asking my patients every Friday when I teach, lifestyle medicine clinics, is why are we meeting? Yes, we are professionals, from a healthcare perspective. But at the end of the day, we are just as human as any one of our patients. So any of these medical ailments and inflictions that burden our patients, they burden us too. And believe it or not, the leading cause of death amongst American cardiologists continues to be heart disease. And that in itself is a whole presentation. But the bottom line is we all want to be healthy at a personal level. So live the lives that we want to impart onto our own patients, friends, and family. Because like Gandhi himself said, be the change that you want to bring to the world. And the main objective of this presentation, if you want to look at this as a PowerPoint, I want this information to transition into a personal commitment, both at a personal level and a professional level. And if you view this as some type of a monotonous lecture, I want that to transition into your lifestyle. So that is my main objective of this presentation. And so the opening comment that I want to make is that we want to ask ourselves, what does health actually mean to us? And it turns out there is a time-honored and a time-tested definition, which I believe was put forth by the World Health Organization at the very beginning of its foundation in 1948, that health is just not the mere absence of disease or infirmity, but the total presence of social and emotional and psychological well-being. And one may even go on to add the word spiritual component to it because it works for a lot of people. And health, when I say health is an inside job, for discussions such as this, the very word in English, healthy, can be broken apart into heal thyself. To make it even better, in Sanskrit or Hindi, the word healthy is swasth, which is literally, I don't even have to break it up, but from a grammatic and the roots of origin of Hindi and Sanskrit language is inner self. That's what swasth actually literally means. So in terms of coming to personal responsibility, although this is an American newspaper way back when I was a 5-year-old kid, but the idea of preventive medicine is faintly un-American. It means recognizing that the enemy is us. And unfortunately, when it comes to the current chronic disease burden, this statement from literally a generation ago is probably applicable to the entire global population. So if I were to ask you, like what I do with my patients on Friday afternoons, each one of you, put you on the spot for a second or two and ask you, why do you want to be healthy? No matter how descriptive, how detailed, and how emotional and how passionate your answers are, there are only two reasons why a human being wants to be healthy. One is we want a good quality of life. Each one of us may define quality of life very differently, right? For one person, it may be able to just go down the street, walk the dog, pick up the mail. For another person, is to be able to run a marathon at 65. But they all kind of fit nicely into the component of quality of life. The second one is longevity, right? We want to live as long as possible while maintaining as healthy of a life as possible. So please stop me right here if somebody has a third reason as to why anybody wants to be healthy. I can't think of a third reason why any one of us want to be healthy. Although I am showing these two entities as two separate boxes, as you all know, these are inseparable. They are like the two sides of a coin. So what I would like to do is take you through the journey of the past century in India as to how life used to look like using quality of life and the quantity of life. And about 100 years ago, an average Indian, believe it or not, life expectancy was 29 years. An average Indian died at the age of 29 in 1920. And unfortunately, the quality of life dwindled down, and the life's graph at that point in time would have looked like a triangle, because they did not have access to majority of the contemporary Indians take for granted in native India, including universal vaccination, clean drinking water. And some of these issues may still be an issue, but tremendous progress in the sense that in 2022, the average life expectancy is somewhere between 65 to 68. But unfortunately, today's curve plotted against quality of life and longevity kind of looks like that. A bizarre convoluted shape down the slope of which is a never-ending accumulation of disease burden. Childhood obesity is on the rise in India like I never imagined possible. Hypertension is the most common diagnosis anywhere in the world, probably the world's capital being India. And please tell me if you know a household where the husband and wife are more than 40, 45 years of age, and at least one person is not popping a hypertensive medication on a daily basis. Diabetes, you don't need me to tell you, India is now officially the world's capital. And so is India is the world's capital of male sexual dysfunction. Heart disease, we hear every single day, premature event in a celebrity or even a regular person. Chronic kidney disease is on the rise. People ending up on hemodialysis, a cancer or two. Yes. Guess what, folks? We are living longer, but we are also dying longer. I don't know the data for India, but in America, we have a metric called quality of life years, right? Quality adjusted life years. Trust me when I say that in America, an average person while living longer is losing about 24 years, 24.6 years due to loss of quality. Meaning, yes, I'm alive, but I'm not able to walk the dog down the street because I just got amputated because of uncontrolled diabetes. I'm not able to go on a cruise vacation with my family because I'm hooked up to a dialysis machine. I'm not able to enjoy a holiday festival meal with my family because I'm in a nursing home after a stroke with a feeding tube. But guess what? I'm alive. So what I argue, or what anybody in the contemporary lifestyle medicine would argue, is that now us humans of current generation have a unique luxury of not being killed by two things that killed humans as long as we've existed on the planet: lack of food and infection. Right? Even in the era of COVID, a vastly preventable heart disease killed twice as many people as did COVID in year 2020. The numbers for 2021 will be out soon, will be exactly the same. So now that we have so much control, is it unreasonable to ask of ourselves as professionals and educate our patients to live lives in such a way that the quality of life remains at a very high level for as long as we shall live? And I randomly chose live long, and I randomly chose 100 years, and then you die short. So social anthropologists call this graph from a transition from a life that looked like a triangle to a life that looks like a box. Social anthropologists call this the rectangularization of life. I simply call it the life in a box, because no matter how hard we try, one day or the other, we are all going to end up in a box, right? Like the old saying goes, I want to die young, but way late. Or my favorite ones is, I may be paraphrasing this, Dr. Kim Williams, who was the past president and a legend in the field of lifestyle medicine and plant-based nutrition, famously said once that I'm not afraid of dying. I just don't want it to be my fault. Right. So now let's get into the weeds, if you will. Current status of cardiovascular disease burden in India. At the turn of the century, believe it or not, heart disease ends up becoming the leading cause of in India also. No longer infectious diseases. And compared to the rest of the world, an average Indian is experiencing a heart attack and dying from it at least 10 years earlier, a decade earlier. That's an enormous amount of life lost. And deaths before age 70, if we put all the deaths before age 70, and you compare India to the rest of the world and the Western population is about 23%. Only 23% of the deaths in the Western population are happening before age 70. In India, it's 52%. And a vast majority, these are all not any deaths, these are CVD deaths, by the way. And for every death, for every case, the case fatality rate tends to be out of proportionately high in India. And that is true both in urban and rural populations. And this huge epidemiological shift, where there has been a 50% reduction in mortality due to malnutrition and infection, like I said earlier, has led to a significant increase in life expectancy from, in a very short period of time, from 58 to 65 years of age. And because of that, and also recent in the past 25 to 30 years, affluent and a little bit more of a money flow due to various reasons, the dietary patterns and the total lifestyle has changed very, very rapidly, right? Both in urban and rural areas. And 25% of all deaths in India are currently due to cardiovascular disease. And compared to 100,000 population, rest of the world is about 235 per 100,000 people. In India, it's 272 people per 100,000. And ischemic heart disease and stroke are currently contributing to 83% of all of CVD in India. Okay, and within a very short period of time, I left India in 1994. This happened after I left, and it continues to go, is that 59% increase in the lives lost due to CVD in India. A very short period of time. And there is this notion that, this is just happening in, rural, urban areas where there's McDonald's or Pizza Huts were popping up, like Dr. Bernard was alluding to. But although the absolute numbers may be high in rural or urban areas, what is shocking is that the proportionate growth of risk factors and disease burden of cardiovascular disease has been much higher in rural areas. And the cost is enormous. And this is a dated slide from 2015, but $250 in cost, just financial component of it, not to mention the human cost to it. So why is there such a burden, right? During Dr. Bernard's Q&A session, one of you had asked, why is there such a burden? Can we do some research in India? And you'll be surprised how much research has been done in India. Right? As of today, 30% of people are smoking or using some type of tobacco. And there are some states in India, as of today, close to 70% of people are actively using tobacco. And the usage is actually on the rise among Indian youth. Hypertension, close to a third of Indian population that we know of, which maybe I'm willing to bet that I think it's a tip of the iceberg. 30% of Indian households are hypertensive that we know of, and is expected to go exponentially by 2025, which is just around the corner. And this is one unique exception. This is very unique, unfortunately in a negative way, that is very uniquely Indian, because the rest of the world, at least the rest of the Western world, primarily due to past 20, 30 years of relentless campaign by many organizations, the prevalence of hypertension has actually gone down. India is one country that is an exception where the prevalence of hypertension is actually going up. Diabetes, again, these are numbers that are unimaginable compared to when I was a medical student in Hyderabad, right? Doubled in urban areas, right? But quadrupled in rural areas, all this very similar to other risk factors, right? And again, what we know about diabetes in India because of lack of access in some of the rural villages may just be tip of the iceberg. But what is shocking and surprising, and that should alarm all of us, is that as a proportionate increase, there has been a quadrupling of type 2 diabetes in Indian rural areas, right? Only 20% of the Indian population has a normal lipid profile. 80% of the Indian population has some atherogenic hyperlipidemia. And if you look at from various cities and from various towns and various cities in India, it is significantly increasing. And what is shocking is that there's an increasing trend over time, and there's huge geographic variations. But if you see a consistent theme, LDLs continue to be higher and total cholesterol continues to be higher, right? And unfortunately, even in rural urban areas where there is some much better access to healthcare, only 5 to 10% of individuals have lipids at a controlled numbers. And obesity is on the rise. Again, you see this a lot more than I do, and it is rapidly increasing. And a combination of 52 studies, all done in India, are clearly showing close to 20% of Indian children are currently overweight. 20%, 1 in 5 children is currently overweight. And it is predicted by this year, by the end of this year, it is predicted close to 50% of Indian women will be overweight or obese. Things that I would have never imagined. Same thing with physical activity, right? 50% of Indian population is not physically active as defined by the guidelines, right? Less than 10% of the Indian population is involved in recreational physical activity, like playing a sport for fun. And fat intake, yes. And these are beautiful slides alluding to the prior question that came up in the last presentation about, Indians being vegetarian. Yes, but I hate to say it this way, but our vegetarianism is a pseudo-vegetarianism, at least the current version of it, right? Because while it's vegetarian, it is refined carbohydrates mixed with trans fats, right? As some of you know, it's only this year, actually last year, 2021, middle of 2021, at the national level, the Indian central government lowered the requirement, what is allowed as a trans fat in Indian, fats. And luckily, most of the industry agreed to do it, which is a good thing, right? Significant increase in, these processed carbohydrates, oils combined with processed ultra-refined carbohydrates, right? And on top of that, per capita meat consumption has gone up enormously. And on top of that, the Western dietary patterns are now become the new normal Indian dietary patterns, right? Quickly and rapidly moving away from the traditional Indian habits of eating fresh produce that most of us used to grow in our backyards. Fresh lentils, and we have no shortage of variety of lentils. There are more lentils in India than probably stars in the galaxy. So same thing with beans. And yet we're moving away from them, right? And look at this, the rapid growth of soda sales in India, 14,000 crores of rupees a year. And highly processed food, these type of foods, most of you who are my age, 50, 52, 53 years of age, we never even seen these foods as kids in India. But every time I visit India, everybody is wanting me to go to all these places. I said, no, please don't take me to these restaurants, right? How about this? Fruit juices, right? This is a beautiful paper that I really like showing this, published in a fairly respected medical journal here in the US, that dietary patterns of children, 51% of Indian children are consuming more than 4 times a week of fruit juices. 21% are consuming carbonated beverages more than 4 times a week. 18% more than 4 times a week of sweetened beverages, and 20% more than 4 servings a week. I don't remember the last time I ate 4 servings of ice cream a week, not even as a kid. It was not readily available. And this is a beautiful paper. Some of you may know Dr. Prabhakaran, a legendary figure from All India Institute of Medical Sciences. And he actually compared the DALY, the disability adjusted loss of years, how India compares to United States. And it is, trust me when I say this, some of the statistics from India make some of our really, really bad, health from a health perspective states in the US. So the numbers are rapidly growing. So how can we fix this? It's easy to kind of point and say, hey, there's a problem. But the real question is, how can we fix this? And I see the answer in lifestyle medicine. And when I say lifestyle medicine, I'm not here to sell you a product, a book, or some, my gym membership in my private club. So these are the pillars of lifestyle medicine, folks. And if you kind of take a bird's eye view at this, except having to pay for your food, right? In most cases, all the other 5 pillars are pretty much free and add enormous amount of quality and life to years. And the reason as a cardiologist that I believe in lifestyle medicine is this. These are the risk factors for heart disease. And some of you may know this, that a lot of Indian data was included in this paper, the famous InterHeart paper that clearly showed that's the risk of some heart disease from smoking. That's the risk from diabetes. That's the risk from high blood pressure. That's the risk from cholesterol. So far, almost all of them, actually all of them, are lifestyle medicine, and a combination of 3 and a combination of 4. And to that, you add obesity. So the reason lifestyle medicine comes into this is to imagine, just take a look at this, what happens to the hazard ratios the minute you add psychological and social factors, right? The risk goes up exponentially. So social risk factors and psychological risk factors are extremely underappreciated, and people are not talking about it, and we don't counsel our patients about it. So what is my why? I ask you, what is your why? And I borrow, kind of some strength from Christian Barnard, who was none other than the man who invented and pioneered cardiac transplantation. He famously said that I have saved the lives of 150 people by heart transplantations. If I had focused on preventive medicine earlier, I would have saved 150 million. And that's why I do this. So the question is, why do you want to be healthy? Right? I asked that question earlier. But to get into all of this, right, it's easy for us to sit here and say, hey, change your diet, exercise regularly, sleep more, don't smoke. When the rubber hits the road, there are a lot of barriers: personal, interpersonal, family support, social reasons, many ways that life drags us. But the question, when I say be mindful, I want you to be mindful about the answer that you give when I ask you, why do you want to be healthy? You will come up with an answer. Even for physicians in the audience, do this exercise on yourself. Ask this and write it down. And that's what should be ringing in your ear all the time as to why you want to be healthy. And then you have to adapt a beginner's mind, because if we are asking you, Dr. Barnard or I are asking you to go on a completely 100% plant-based diet, you said, what the heck are you guys talking about? Right? We will show you the data, but on the receiving end, adapt a beginner's mind. Is, you know what? Let me just start and see what happens, and be non-judgmental, and take some time to educate yourself, try different things, and be accepting of both successes, celebrate them, and be accepting of failures, because these things do happen. And don't make it a competition, especially with your neighbors and your family members. And please don't make this a competition about weight loss, right? Because like Dr. Bernard said, you could, the last time we checked, life is not a contest about fitting in a thinner casket. And trust yourself, trust your information. And if we can help you, give us a call. And when you fail, let go. So this is what mindfulness is. Mindfulness is not something to just walk into. You have to actively think about it and look at the problem at hand and look at the challenge and say, you know what, I'm going to do it. And another way of thinking about mindfulness as a physician or as a patient on the receiving end is that everybody is complaining about the rapidly increasing chronic disease burden, the number of diagnoses that we list in a patient's chart. And everybody is complaining about the number of pills a person is taking. But how many of us are actively doing something about it in terms of empowering ourselves as physicians and empowering our patients and their families? Are we doing it? And a simplistic way of looking at it is that, let's say some master of lifestyle medicine accomplished all the goodies and sitting on top of a mountain, hiding in the clouds, but he or she is doing us a favor. They want us to get there, and they're going to throw us a ladder. Guess what? They're going to throw us 2 ladders. One ladder has steps that are 10 feet apart. Another ladder has steps that are 2 feet apart. Which one any one of us would take, right? That's all literally it takes. Drop makes an ocean. Take those steps professionally and personally, and you will get there. And for that, your patients will be better. And in doing so, we will fail. But like Bruce Lee had said once famously, the master has failed more times than the beginner has even tried. And this one, I really like the second one, is that if we are what we repeatedly do, excellence is a habit, not a gift. And so we can all be excellent at this. So what tools do we have? So I talked about the tools. Is it just a talk, or is there any evidence behind these tools? That's the crux of the presentation. Is this just fluff, or is there actually science that supports this? The first and foremost is social relationships. Because if you're asking a 67-year-old patient who lives alone and children are gone to America like I am, and now the person needs, change in lifestyle. That person needs social support. Without that, nothing happens. Nobody succeeds in isolation, and lifestyle and dietary changes are no exception. And the data on this is actually very clear from a legendary researcher who actually was one of the keynote speakers 2 years ago at ACLM. And what she clearly showed is that strong social relationships are actually probably the most important contributor to live a long life, because people who live a life with a sense of purpose, connectedness, and social bonds also tend to do a whole bunch of other things right. And statisticians sometimes call this healthy user bias, but it works. And 20% of people in India right now are mentioning social isolation. I don't know the data for India, but if you're in America and if you're 65 years or older, and if you're self-reporting social isolation, the data is so clear that the CDC actually made a infographic and shows it on their slide, on their website, that the risk of having a myocardial infarction from social isolation is identical to that of a person smoking 15 cigarettes a day. There is a slide. This is right off of CDC. And the reason I say this about tobacco is, you may say, come on, Kaushik, everybody knows about tobacco. Why do you need to talk about tobacco? We all know it's bad. Well, in the US, at least 10 to 15% of the society is still smoking. And it was not too long ago, maybe just a generation and a half, maybe 2 generations ago, America used to allow publication of such ads inside of medical journals. And if anybody wants to take a deep dive, I strongly suggest that book, The Cigarette, because learning about some of these tactics will help you as to what's going on today in the global food industry. So smoking in India is again, like I said, some of the most recent reports is about 28 to 30%. Women smoking bidis is not uncommon. It's actually fairly common. And there are some districts in the state that I come from. They actually smoke the bidi with the burning end inside the mouth, not outside. Some of you may know this. Alcohol, this guy says drink responsibly means don't spill it. So one of the things that, yes, open disclosure, I about 2-3 years ago, I used to drink once in a while a small glass of wine, but it is listed as a group 1 carcinogen. So if you drink alcohol, even in, moderation, and somebody asked, used that word earlier as to what moderation is. So psychologists ask this question, what does moderation mean? So to me, a glass of wine may be moderation. To another person, a bottle of wine is moderation. So it turns out when you objectively question as to what moderation means, it is whatever makes that person happy. But in terms of the science of it, alcohol is listed as a group 1 carcinogen. So minimize or eliminate it. And there's some data that, alcohol may help you with cardiovascular health. And the question is compared to what? Just look at the outcomes from atrial fibrillation. Look at the outcomes from stroke and alcohol use. So my friendly suggestion is that if you drink for 30 other reasons, but please don't drink thinking that it's going to help you live longer. Emotional stress is an extremely important component of human health and an extremely central pillar to lifestyle medicine. But unfortunately, this is not evaluated properly, at least within the circles of American cardiovascular medicine practice. Up until I got into lifestyle medicine space, I did not, entertain this discussion with my patients. Now it is an integral part of literally every single conversation, both inpatient and outpatient. And emotional stress is a very, very, very common problem in India. But for whatever reasons, Indian society is not as open as we should be about talking about this. And the mechanisms, there are a couple of new papers. This slide is a couple of years old. There's another beautiful paper published about 2 weeks ago from Harvard. I'll be more than happy to link it later. Basically, cardiovascular link between emotional stress. Mostly it is sympathetic nervous system driven, but affects literally all aspects of atherosclerosis and atherobiology. And depression and CVD, again, if anybody is interested in this field, I strongly urge you to read that paper from 2019. It's a beautifully written template as to how a cardiologist or even a primary care doctor could use some simple depression screening tools, because close to 50 to 60% of patients with CVD or any heart disease suffer from depression that is not being addressed clinically. And socioeconomic stress, especially, and we all have some degree of socioeconomic stress, right? Depending on how you look at life. But there are some people who are really suffering from a societal lack of fairness, discrimination for various reasons, and not to mention COVID over the past 2 years has done a number on all of our social and professional aspects. So socioeconomic stress is an extremely important part, and this should be a component of regular lifestyle medicine evaluation because it has direct implications on cardiovascular health. And the mind, in terms of the outlook, I'm talking to an Indian audience, and sorry for writing this in English, but this from, Adi Shankara's teachings that yet bhavam tad bhavati, meaning that world is a manifestation of your thought. Easier said than done, but that's when, the mindfulness practices come into picture. Used to be, and Dr. Dean Ornish, if you go through his life story, when he was a teenager, what an exemplary life to turn around and what he has accomplished. And physical activity, right? This is a joke out of this, but things are very simple. When we say physical activity, yes, these are American Heart Association guidelines. I don't think the guidelines would be any different for the Indian society either. So simple things, a 30-minute walk, right? When we say exercise, we are not expecting everybody to come back next week with a six-pack abs and a supermodel body. Just pick up a regular walking program. If you're unable to walk, all that you can do is to sit in a chair or a sofa, just move whatever you can move. And sometimes you may need, a special, counseling and a special help with this. But the beauty is that if you already have heart disease, all that you really need to do from being a couch potato or completely inactive, the most benefit is not from running marathons or half marathons. It's very little, actually, 10 to 15 minutes of walking a day. That's all. That's all we are asking is to start, is to 10 to 15 minutes of walking a day, right? Because a body in motion stays in motion. So the big one, right? This is what a lot of people probably want to hear, is the nutrition component. right? So, sometimes, I was speaking someplace, almost like a debate type of situation without, putting it much thought. I said, while ketos and phytos are fighting the battle, because one of you asked a question about keto diet, the Cheetos are winning the war. What I mean by that is that while there is this huge debate globally about plant-based diet as meat-based diet, in a society at large, unfortunately, from an industry point of view, the people who are winning the battle are the people who are selling us processed food. So one of the things that I want to convey to you is that when you think of nutrition, please don't think food. Food does not exist from a consumption of calories. From an evolutionary perspective, food does not exist. You don't go to a banana plantation and pick up carbohydrates. You don't go under a mango tree and you pick up, cholesterol. Well, we certainly don't, but I'm just, you don't pick up sugar. So food does not exist. Fats, carbohydrates, and protein are macromolecules that are buried somewhere in that intimidating chapter number 3 in a biochemistry textbook. And also, when was the last time any one of you went to a grocery store in India and said to yourself, honey, I'm going to bring home 7 carbohydrates, 8 fats, and 9 sugars? Does anybody think of food that way? Right? From a pure consumption point of view, body looks at the nutrient density and the caloric density of the food. So along those lines, this is enemy number 1. Public number enemy 1 is a beautiful paper done at NIH showing in a very short period of time what ultra-processed foods do to the human body. Is to give up eating these foods. And I'm going to start with hypertension and nutrition, right? Which is because it is the most prevalent condition. And as per the 2020 global burden of cardiovascular disease data, hypertension is the leading cause of cardiovascular disease, disability, and death. And no cardiovascular risk factor is more amenable and more responsive to dietary changes. And here is the proof. In the US, if I were to invent a new drug for blood pressure, the requirement by the FDA to have it approved after I show efficacy and safety is a mere drop in 3 millimeters of systolic blood pressure. That's all I need to show them to have it approved. Predominantly a plant, not even 100%, predominantly a plant-based dietary pattern, also known as the DASH diet, which again supported by a class 1 indication, with moderate salt restriction has the potential to drop a person's blood pressure by 22 millimeters at the end of 1 month compliance. Not even 100% plant-based diet. Imagine what's possible. And hence, it's supported. There are very, very few conditions, folks, in all of cardiovascular medicine that are supported by class 1 and level A of evidence. One of them is a plant-predominant DASH diet. And yet, when was the last time any one of you talked to your patients about DASH diet? Same thing with lipids, right? Some of this data is actually published by Dr. Barnard and his team. Right, clearly showed and made it to the guidelines level that where the intent of treatment is primary prevention, portfolio diet by Dr. Jenkins and his team. Clearly showing, made it to the guidelines where the number 1 thing that we should be doing for lipid lowering is lifestyle. Through even the 2019 and 2021 European Society of Guidelines are clearly saying to eat a plant-predominant diet. Same thing with diabetes, based on these 3 large trials, right? The American Diabetes Association supports many dietary patterns, and for various reasons, they included a low carbohydrate diet in the most recent guidelines. But if you look at the most recent updated version of American Diabetes Association guidelines, one thing is clear. There are about 3 randomized controlled trials that now have close to 30-year follow-ups, right? Their consistent theme is one, when it comes to nutrition, is a plant-predominant diet. The American Diabetes and the American Academy of Clinical Endocrinology, they go even a step further than ADA and basically clearly stating that lifestyle therapy when it comes to type 2 diabetes for all patients, primarily a plant-based meal plan. And if anybody wants to take a deep dive as a physician or even for your patients, I strongly suggest you read this book by Dr. Roy Taylor, whom I had the luxury of introducing and having at a presentation at the last American College of Lifestyle Medicine meeting. It's a very, very useful book. And so where do we stand with guidelines? These are the 2019 American College of Cardiology guidelines, which are practical and applicable. Yes, the dietary pattern is going to change with the culture, but overall message is the same: to eat a plant predominant diet with a class 1 indication. What I don't have here, I apologize for this because it is still not in print yet. The 2021 came out in late November, the 21 European Society of Cardiology guidelines for cardiovascular prevention. It's almost a 140-page document with similar tables with core of evidence and level of evidence. Of all the tables that are listed in that 30-page document, there's only one table that has all green boxes with the number Roman numeral 1 written to it. It is about a plant predominant diet. And I strongly urge you to look it up. European Society of Cardiology, 2021 Prevention Guidelines. So when we say plant-based diet, there are a lot of other things that are plant-based. French fries, cookies, and sodas are also plant-based, right? And we have a very nice paper by Dr. Satija and et al. Published a few years ago, clearly showing that the healthy plant-based diet index, just something is plant-based doesn't mean it's healthy. It has to be a whole food, unprocessed plant-based foods. And now there's this lot of craze around these plant meat-based alternatives, which are a good transition foods, but they are loaded with, some of them are loaded with saturated fat because they add a lot of coconut oil to it. So be very careful with it. So when people say that eat a plant-based diet or, vegan diet, the society's perception is unfortunately that we pick up grass from our lawns and throw some wilted tomatoes and eat it, or eat like rabbits. But in reality, using these very simple, very inexpensive, readily available, especially in India, you can make amazing meals like this, except for one picture here. Every meal is homemade. We made it, almost all these meals here. Okay. And to put it in the words of my good friend, Jeff, is don't eat crap. Food that is calorie rich and processed. And the legend, the nutrition journalist, Michael Pollan, eat food, not too much, mostly plants. So here is a plate that we put forth through the American College of Lifestyle Medicine, Dr. Bernard's organization. Again, I strongly suggest that for those of you who are in India, PCRM actually has a lot of resources to cook Indian food. And I've tried a few of them myself. So sleep is an underappreciated component of human health. Nobody said it better than Gandhi himself, that each night when I go to sleep, I die. And the next morning when I wake up, I am reborn. And this is so true, because if you look at almost all cardiovascular outcomes, the sweet spot tends to be somewhere around 7 to 8 hours. But this is, believe it or not, India is one of the most sleep-deprived nations on the planet. When I looked at the data, it just blew my mind. And especially Indians who are living in this country, working especially in the IT industry. They are probably some of the most sleep-deprived people living in this country. And we now have bidirectional association from an epidemiological point of view. And when you see a bidirectional association, you can draw a causal inference, meaning that this lack of sleep itself is the cause of cardiovascular disease. Same thing with diabetes, 7 to 8 hours. Same thing with cancer risk. So much so, night shift work is officially classified as a probable carcinogen. Probable carcinogen, because night shift work comes with many other negative lifestyle factors. So summary with sleep is, don't let it be a dream. After all of this, after all the pillars being covered, we see this, right? Ganguly survived, but 2 back-to-back heart attacks and 4 stents, a world-renowned super athlete. What is going on? These are men who are living an exemplary life, like supermodels and super cricketers. What happened? This happened, folks. Doc, the damn disease runs in my family. So I'm going to read something to you all here. There are no older men in my family. All branches of my family tree have been cut short by cardiovascular disease. I believe the people in this room have the power and even the duty to change that. Those were the words by the then president of American Heart Association, John Warner, who at the age of 49, a day before delivering his presidential address, to the American Heart Association in Anaheim, California, had a cardiac arrest, and almost died on the floor of the official meeting hall. He had to be shocked twice, airlifted, undergo an emergency percutaneous coronary intervention with 2 stents to the LAD, and the words in the first 2 bullets were spoken by him after he recovered a day after through Skype. And I strongly urge you to use those 2 links from the American Heart Association at the bottom to actually hear this story from his own words. So is this true? Is this true? Is how much of this cardiovascular disease is genetic, as we hear in India? Because as young people are dropping on a weekly basis, young celebrities are dropping, young movie stars, young people who look like models are dropping on a weekly basis. Are we to blame all of this on genetics? So we now have the luxury of polygenic scores, which are becoming fairly clinically available in the US right now, right? So using these 3 large transcontinental databases, right, we are able to compile close to 60,000 samples of humans whose life history has evolved. And then went back and looked at what would happen to you if you were to have a high genetic predisposition of a polygenic risk score to have a cardiovascular event, but you led a healthy lifestyle. How do you define a healthy lifestyle? This is where you're going to laugh. They defined a healthy lifestyle so weak that if you quit smoking a day prior, you're counted as a non-smoker. And they allowed a BMI of up to 30, physical activity 1 day a week. And you, as long as you stuck to at least half of what American Heart Association wants you to eat, you are a quote unquote a healthy eater. So by no means a perfect definition. By no means this definition would ever even enter the halls of PCRM. And yet, with that mediocre definition of lifestyle, even in the setting of a high genetic risk, the event rate went down by 50%. I'm going to say it again. Even in the setting of a high genetic risk, if you live a healthy lifestyle, the risk of actual clinical event can be reduced by 50%. For MI, actually 62% from a UK Biobank paper, which I don't think I have on this slide deck, for exact same data is shown for stroke. So what we know from this classic paper, which is aptly titled as Healthy Living is the Best Revenge, what we know is that by following those simple 6 pillars of healthy living, you can lower the risk of any chronic disease by 78%, diabetes by 93%, MI by 81%, stroke by 50%, cancer by almost 40%. Show me a pill that can do this. Show me a procedure, certainly not the ones that I do for a living, that can do this. So this is an issue that can no longer wait, people. This is an issue that can no longer wait. This undertaking will present a challenge, and the traditional treatments like what I do will always have a place. But the direction that the cardiovascular clinicians need to take to more holistically treat their patients. And these were not words by any man, but Valentin Fuster, who is one of the living legends in cardiovascular medicine. So we have an onus. What we have created globally is that we have created a disease management system where hardly any emphasis on primary prevention and public health. So all of us across the world, we have an onus to lend a forceful hand to flip the pyramid, because it takes 5 to make a fist. It's not going to be easy, but we have to be the change that we want to bring to the world. And we have to spin this pyramid. We have to spin this wheel like it's our last run. So some of the simple tips for the Indian gene pool is to keep your A1Cs below 6, keep your waist circumference, but the better metric for anybody, because the whole metabolic syndrome definition could be a little different for India, is probably a better anthropometric measurement for India would be height to waist ratio. Don't let your circumference around your belly button exceed more than half of your height. If it does, it doesn't matter how many bench presses you can do or how many push-ups you can do. It's very telling of there being truncal adiposity, which is an inflammatory organ by itself. So shoot for a BMI of probably less than 22. Here it says 23. Keep a check on lipoprotein little a. Not that there is anything we can do about it, But there, the type of lipoprotein little a in Indians is very different compared to what we have here in the US. Is one of the highest numbers or in African Americans, but somehow it's a different biology in terms of the isoform that we have here for African Americans. But at least in an African American population, there is a nice paper from Houston that showed even lipoprotein little a can be lowered by about 15 to 17%. So total cholesterol, keep it at somewhere between 150, 160. Keep your LDLs somewhere between 50 to 70. Don't fall for this. Everything, 130 is normal. It's not, because you'll be surprised. Close to 20% of people with LDLs of 70 have actually asymptomatic atherosclerosis. Triglycerides are a huge problem in India because we consume so much processed foods, processed carbohydrates mixed with processed fats, right? Vegetables, people, lentils, beans, greens, right? Like our grandparents used to eat. If anybody wants to read, this is a beautiful paper by none other than Dr. Enos, who has created an amazing legendary database on Indian cardiovascular disease. CADI, C-A-D-I is his website. Calcium score, when in doubt, is a very useful tool. When in doubt, as a risk enhancer, use it. We can do an entire talk on this. So I will stop there. And, I'm fairly active on Twitter, and the nonprofit that I run here in Tampa is called PBLM, Plant-Based Lifestyle Movement.org. And if I went over my designated time, my apologies, and I will be more than happy to take any questions at this stage.
Thank you, Kaushik. Just one for the audience to know, he's an alum of Gandhi Medical College, 1985 batch. Very, very outstanding presentation. We're honored and so proud of you, Kaushik, for all the work you do and the leading efforts, and as a shining example, and you actually follow what you preach. So thank you very much. This was very, very informative. I'm sure everybody in this audience are excited to ask questions. Here is...
Quick question, Dr. Kaushik. Wonderful talk. Question I have, our parents, grandparents, and ancestors, they have been using desi ghee for years and years, pure desi ghee. What do you think about that?
So desi ghee has enormous concentrations of LDLs, or, it's actually, the oxidized LDL, actually concentrations of oxidized LDL go up. And yes, but so the traditions, yes, they've been using it. But as I showed earlier, only 100 years ago, an average Indian person was dying at 29. And did we study their heart disease conditions? We do it as a pattern, but, as we live longer, we want to do things that are going to keep us healthier. And the only way to find out, I don't want to make a large, broader cultural statement that everybody in India should stop ghee. On an individual basis, the only way to find that out is if it is a concern to you personally or to your family or your patients, is stop ghee for a month and have your cholesterol repeated and see what happens. And that to me is the best way to connect with this, because when I say lifestyle medicine, you cannot do a blanket statement that every human being has to stop ghee. It's just not going to work that way. And the best way to do it is that, what is this conflicting data I'm hearing? Okay, my grandparents did that. I'm from a small village not too far from where you are. I'm from Bongir, a small village from next to Bongir, and I grew up on a dairy farm. And up until 6 years ago, I used to eat yogurt, ghee, like the bucket load. And then my lipid profile changed. My LDL right now without any treatment is 47. Like what I was born with, what a human being without any genetic condition is born with is 47. And if you get there, if your ApoB and LDL gets to 47 to 50 and your total cholesterol is below 150, for all practical purposes, unless you pick up tobacco, you will be, for, there are exceptions to this. For all practical purposes, you will be heart attack proof. So the best way to find out is to stop ghee for a month and see what happens. But it does, the recommendation is it's loaded with saturated fat, and the data on saturated fat elevating LDL and ApoB is so clear. The basic biology behind those concepts, lipid hypothesis, is now backed by 4 Nobel Prizes.
Hi, Kaushik. I am Raju. It was an awesome presentation. Each slide is a gem. My question is for an Indian, South Indian family, where we generally incorporate ghee and honey and all these things in our diet and try to imitate people that honey is better or jaggery is better than sugar. Such notions are there. And how to involve our family into the process of adopting whole food plant-based diet.
So think about it, right? So if you think about, when again, for those of you who don't know me, Raju and I were good friends. He and I went to medical school together in Gandhi. We're from the same class. So thank you for joining, Raju. Good to hear your voice. So if you think about it, I remember when I was a kid growing up in India, when we woke up, right, we eat, different types of beans for breakfast in the village. Right? These highly processed sugars are, at the current level of consumption are relatively a new part. So again, am I going to tell everybody you should never eat jaggery or you should never eat honey? That just is not going to be practical. At the end of the day, you want to make sure that your energy consumption, what you take in, should end up being less than what you end up burning. Otherwise, it's just not going to work. And one of the beauties with a whole food plant-based diet is that it's very difficult to overconsume. Just imagine that instead of eating, processed carbohydrates for breakfast, eat a large bowl of steamed vegetables, right? Cook them with, Indian spices. You'll be surprised that you can cook 90% of Indian food without a single drop of oil. We do it here all the time. Right? And then you will realize, that's with sugar. Let's stay with sugar. Yeah. So in terms of a pure science of it, the glycemic index of almost all sugars, including honey, agave nectar, is almost identical. So if you really, really cannot give up, the processed added sugars, one of the things that you could try, because dates are readily available in India, kharjoor, you can take the kharjoor, take the seeds out, and boil them in a pot of water, 10 to 15 of them, right, in a pot of water, and let the water sit. And when the water cools, put them in a grinder, blend it, right? Guess what? You made yourself a cup of a nice little dish full of homemade date syrup, where the fiber has not left the food. Right? I mean, that's exactly what I do every single morning. I just leave the house around 5:30 or 6 o'clock in the morning with a cup of tea. That's it. With one teaspoon of homemade date syrup. So there are alternatives around it. There are traditional ways. Again, the key here is whole foods. Whole foods, not extracted sugars, not extracted oils, not extracted carbohydrates, not extracted fats, that kind of stuff. I don't know if I answered your question, Raju, and how do you encourage family to do it? Again, one of my uncle recently had a non-ST elevation myocardial infarction, had to be rushed to a bypass operation. So mom calls me and I'm talking to him on the phone and I'm talking to my atama on the phone. And I told them, guys, look, you had to wait till your chest having to be cracked open to make a dietary change. Why don't we open the mouth a little differently and eat food differently? So within 10 days, he reduced his insulin consumption by 80% that he struggled with for 22 years. He was not starving. I just asked him to go back and eat, gugil, I don't know what they're even called in English, right? And eat those for breakfast, right? Eat chana, right? Chana with some other vegetables, with cilantro, some fresh onions and a slice of lime with a touch of salt or black pepper. Eat that for breakfast, lunch, or dinner. Just who cares? So we, from a family point of view, the family, each individual in the family has to take true ownership. We have to stop for a day or two and think through every meal and also every component of our lifestyle and say, can we try something differently for a month? At the end of the month, you find out your sugars are better, your cholesterol number dropped, you're no longer taking a blood pressure. Don't let me run your life. And as a family, you have to decide, hey, wow, this blood pressure pill I've been taking for 20 years, within 3 weeks, I'm stopping it. What do I want to do? What do I want to do now? So it has to be a very, it has to come from within. Lifestyle changes are not going to happen because you're hearing some crazy guy from other side of the world lecturing to you. It has to come from within. And hence, for every one of your family member, ask them the question, have them write it down. Why do you want to be healthy? And if your father and mother says, or for children, if your father says, I want to be healthy, challenge them. If you want to be healthy, why are you drinking so much every day? If you want to be healthy, why are you not going for a walk every day? If you're healthy, why are you eating chicken biryani for dinner every night? Right? That kind of stuff. It has to come from within and it has to be personal.
Yeah, this is my last question. How to overcome this? Is caffeine okay? Black coffee per day?
Yeah. Okay. Absolutely. Absolutely. That there's this whole thing about
curd rice.
Oh yeah.
And
No.
South Indian curd rice, giving up curd.
Well, yeah, giving up curd, giving up sugars, giving up yogurt, and giving up, dairy products, and giving up. It's going to be a struggle, especially because it is such an integral part. So, first question: caffeine. Unless you drink bucket loads of caffeine, is actually not bad. There's actually some data up to 4 to 6 cups of coffee actually may be helpful. Right? Even actually, there's a couple of really good papers that came out in the past couple of years that even if you have some mild forms of atrial arrhythmias, we used to tell people don't drink caffeine. That even may not be true, but it also depends on how much you drink and how you respond to it, right? And also, how do you prepare your coffee? And if you go to Starbucks, which is now a commonplace in India, they convert coffee into a sugar syrup with a whipped cream and more sugar on top of it. That's not coffee. Now, coffee is like, if you want to drink coffee, like, the brew coffee in the stainless steel cup, I used to love them. Now I just make them with soy milk. That's question one. And the question two was about, what was the question again, Roz? The second one that you asked just now? About
yogurt. Giving up curd.
Yogurt. Yeah. So again, try to minimize it. Again, it depends on where you are in the totality. If you're eating 90%, or 90% of your calories from a unprocessed, a whole food, plant-based diet. And if you're struggling that you cannot give up dairy because you're hooked onto it, you've done it from childhood, eat a small cup of yogurt, but compared to what you were eating before, you're much better. And in my personal journey, giving up my mom's Indian chicken curry was easy. Giving up a cup of yogurt was the most difficult thing I've ever done in my life because it's almost addictive, but it took me 6 months, but I gave up almost 6 years ago now. And we figured out a way. And luckily, for us in the US, all types of nut milks are made into yogurt. We have almond yogurt, we have soy yogurt, we have oat yogurt. All of them are readily made in the stores. But if you're a little creative, you can actually make these yogurts with the soy milk and almond milk even at home. It can be done, but do you absolutely have to give up? It all depends on the totality of what else are you doing and what is your health goal, right? I cannot just say that every human being, because believe it or not, there is some data that dairy may be protective, but it also depends on how many calories that you're eating. If you go to sub-Saharan Africa, in the rural villages in India, where back when I was a kid, the only milk that we used to get was sometimes the US made powdered milk. So if you look at those subsets, the caloric intake, then the prevention of malnutrition through dairy products may actually be beneficial. But if you're eating abundant calories and you're getting all the nutrients, is there a biological need? That's the question you want to ask. Is there a biological need for a grown human being to be drinking the milk of another mammal for the rest of our life? And the answer is no.
Thank you, Dr. Reddy. We have another question from Dr. Bhatina.
Dr. Reddy, my name is Ravi Bhatina.
Yes, sir.
It's a great talk, and I empathize with your talk because I was like you, 20 years of interventional cardiology, and in the last 18 years, I am a consultant for South Asian Heart Center in San Francisco, mainly focused on lifestyle management.
Wow.
Very well done presentation, doctor. Great. I really want to add one point because everybody talks about the 6 pillars. I call 6 sins. Yes. Salt, sugar, spirits, sedentary habits, sleeplessness, and stress. Everybody knows about this. But in the recent years, there is something else people should talk about. all through these years, talking about cholesterol, heart disease, cholesterol, strokes, there's one more that came, another S, that is sepsis, called inflammation. We are checking in our heart center, not only for lipids and all those things, we are looking for a HCRP, because inflammation, heart disease, coronary artery disease, not due to cholesterol, it is due to inflammation of the endothelium. So HCRP, so what are the things that we're doing to ourselves to increase the inflammation? That's what we have to focus on. Some of our friends in the audience were asking about keto diet. Keto diet is the killer diet, as far as I'm concerned. It causes acidosis, it causes sepsis, inflammation. So anything that can be done to decrease the inflammation is the cure for heart disease. Thank you.
Yeah, absolutely, sir. Absolutely. But I just want to, yes, absolutely. So it's something that we know it's been measured. Paul Ritker from Mass General has done extensive work on this, and his team, the TIMI group, they have published extensive work on this, HSCRP. And just so, since the topic about high sensitive CRP came about, there is a doctor at the NYU, Binita Shah. So what she did, she's an interventional cardiologist. She took about a few hundred patients with established coronary disease, patients who come to the cardiac cath lab for a diagnostic angiogram, and and they got that whatever treatment that they needed, and then they were randomized to a really beautiful done study. They were randomized to not some junk food, but American Heart Association diet, which is a very healthy diet, not 100% plant-based, but a very healthy diet. And the other group was randomized to a complete vegan diet, a healthy vegan diet. And what blew everybody's mind was that compared to an American Heart Association diet, a 100% vegan diet in men with established coronary disease lowered HSCRP by an additional 38%. And a fascinating paper. And so but that being said, inflammation and lipids are not mutually exclusive. They work in sync, because we could have all the inflammation that we have in the body. But if the cholesterol, especially LDL or ApoB lipoprotein, if it is normal, it is almost impossible to develop atherosclerosis, because there's no other final common pathway. That's why Brown and Goldstein, doctors from UT Texas, who won the Nobel Prize for this, they actually called it the obligate risk factor, meaning that without ApoB entering the endothelium, no matter what the damage is, inflammation is a huge factor because of all the 5 S's that you mentioned. The 6th, the sepsis/inflammation, is in our bodies. It can be measured. But if your LDL is 50 and your ApoB is 55, it's extremely unlikely that you would form a plaque. So they are not mutually exclusive, but they work synergistically. And by taking care of the 5 S's, we automatically have a huge chance to lowering the 6th S. I really like that. I'm going to use that. Thank you for sharing that with me. Appreciate that.
Thank you, Dr. Reddy. I especially appreciate for bringing all the data. That's a huge data coming from the Indian population, and we really appreciate that. And then in the interest of time, we're going to have one last question.
Sure.
Kaushik, this is Ramon. I was 2 years senior to you.
Hi, Ramon. How are you? I remember you, man. Of course I remember you. How are you?
Very good. First of all, I want to congratulate on your achievement, and this talk has been wonderful. I just have a quick question about millets. I'd gone to Sadhguru's recently in Tamil Nadu, and they were talking a lot about millets. So you may want to shed some light on that. Thank you.
Yeah, so millets fall into the, there are 2 things, things about, dairy, in terms of small quantities of chicken, why, we can debate, the harms or the benefits, but there are 2 things, there are 2 things that the data in the nutrition science is crystal clear. That is the benefits of vegetables and the benefits of whole grains. And millets are a form of whole grains. And these 2 are the healthiest foods there are on the planet. So absolutely, you know, the people who consume, and, you know, there's this notion about, you know, don't eat carbs. I said, what is a carbohydrate, right? A handful of jonnalu or ragalu, sajjalu, millets, you know, now koral, all these, you know, I'm saying the Telugu names because I'm assuming most of the audience in Hyderabad are Telugu, right? So they're all whole grains. Instead, instead we eat this pizza and all this white flour roti, and they say that is carbohydrates. But if you eat the whole grain, and believe it or not, if you go around the world and look at people who live the longest and the healthiest, close to 70%, 60 to 70% of their daily caloric intake actually comes from carbohydrates. But those carbohydrates are not some junk food, sweet potatoes and Coca-Cola. It is actually sweet potato. Remember, my mom used to feed sweet potatoes to us when we came from school, 4th and 5th class, 6th class, up until I left the village. Our evening snack was sweet potatoes, not pizzas and chips. Sweet potato and water every single day. But we're
Thank you, Kaushik. Yeah. Oh, sorry.
It's all right. Thank you. Sorry again. Yeah, I can. You know, yeah. As you can tell, I'm deeply passionate about this. I can spend a whole day or a week talking about all these details. But yeah, just connect with me on Twitter or kaushik.kaushikreddy@gmail.com, or you can shoot me an email at my nonprofit kaushikreddy@pblm.org. I'll be more than happy to answer questions. Again, thank you for the opportunity and congratulations on the success of this event for the organizers. Appreciate it.
Thank you, Kaushik. This is Murthy. I'm sure you all enjoyed Kaushik's presentation, but I just want to tell you brief comments about coffee. It's inflammatory, and that's how the whole process. In my talk, I'll explain how chronic diseases and all that. Now I want to introduce this ongoing effort, the first attempt. I can't stop thanking Anupama for giving this opportunity of half day of lifestyle medicine. But our goal was from API to connect with the Indian Society of Lifestyle Medicine. How many of you know that even exists? It's called Indian Society of Lifestyle Medicine, ISLM. And I'm very proud that our own Indians, 36 or 26 people, have got board certified. So everybody in this room who is a physician can actually get board certified through American College of Lifestyle Medicine, but it's called different, called IBLM, International Board of Lifestyle Medicine. And you can get board certified. And ISLM has been a transformative force under the leadership of Sheila Nambiar. She's an MD, she's an obstetrician gynecologist, practicing in India, a board certified lifestyle medicine physician from the British Society of Lifestyle Medicine, a fitness consultant, and she's also certified in positive psychologist from UPenn. She's the current president of Indian Society of Lifestyle Medicine, a council member of Global Conglomerates, True Health Initiative, a council member of several other boards. In the interest of time, I'll cut it, but she runs her own wellness program called Training for Life. She runs a hospital. She's a speaker at TEDx and other national and international forums. She's the author of 3 best-selling books on fitness, exercise, and holistic well-being. And one of the books that she wrote was actually being carried out by the union minister. And that's how popular she is on Instagram. It's an honor to invite you, Sheila, because our goal was to see how we can merge or collaborate and start initiatives with API and ISLM. Thank you, Sheila, for being here. Thank you, Kaushik. Can you all please welcome Sheila, please? Well, she's still getting ready. Thank you. Thank you.
Thank you so much for having me. It's indeed a great pleasure and a privilege and an honor to be here with API. I thank Dr. Murthy, Dr. Bojan for facilitating this. And most importantly, I thank Dr. Anupama for even thinking about doing this collaboration, which I'm sure will be of great help to both ISLM as well as API members. So can you see my slides?
Yes, we do.
Yeah. So let me just begin by giving you a very brief introduction. I think Kaushik has already done the honors. It's left it very easy for me. But about 2,500 years ago, the Greek physician Hippocrates stated that in order to keep well, one should simply avoid too much food and too little toil. Let food be thy medicine, and that medicine be thy food is also attributed to him, although there's no real evidence that he said that. Chinese and Greek philosophers have said, use moderation and all things in moderation. In the preface to his book, Lifestyle Medicine, which is one of the first books that were published on lifestyle medicine, James Rippey said that lifestyle medicine will open an entire new branch of medicine, emphasizing the important linkages between clinical practice and the recommendation of positive lifestyle behaviors for patients. So just as a brief introduction, the definition of lifestyle medicine is the use of evidence-based therapeutic lifestyle measures to prevent, manage, and sometimes even reverse chronic non-communicable disease. And these measures may include, but are not restricted to, a whole food, plant-predominant eating pattern, regular physical activity, restorative sleep, stress management, avoidance of risky substances, and positive social connections as a primary modality delivered by clinicians trained and certified in this specialty to prevent, treat, and often reverse chronic disease. So lifestyle medicine is certainly what is required in India. Proper courses, proper protocols for the actual prescription of lifestyle medicine is what is required in India. We in India are not new to the term lifestyle because traditionally you have all our traditional forms of medicine like Ayurveda, which talk about various aspects of lifestyle, like using the right kind of food, the right amount of food, sleep, stress management, breath work, and so on and so forth. But what lifestyle medicine does is use evidence-based protocols for prescription. And this prescription is through allopathic physicians after a board certification through a curriculum that has been formatted by the current American College of Lifestyle Medicine. So American College of Lifestyle Medicine is the first organization of clinicians where lifestyle medicine physicians can come together. And now this has spread globally through the Lifestyle Medicine Global Alliance. Now, talking about the history of the Indian Society of Lifestyle Medicine and lifestyle medicine in India, in 2016, and this is what I'm told, in 2016, 5 Indian physicians, Dr. Ravi Mamtani, Dr. Kaushik, whom you've heard and who you can see very clearly is absolutely passionate about lifestyle medicine, Dr. Angela Reddy, Dr. Karmi Patel, and Dr. George Hansdack. They met after the ACLM conference and talked about starting a similar organization in India. The seed of this idea was sown then, and it is actually becoming a reality today. So fast forward, and in 2017, I came across an announcement for this, the first lifestyle medicine conference by the Asian Society of Lifestyle Medicine in Taipei. And I decided that I would attend it. Now, although as a gynecologist, I've been actually practicing the various aspects of lifestyle medicine, exercise, nutrition, practicing and prescribing it to patients for over 2 decades, I wasn't aware that lifestyle medicine was an actual field until this conference in Taipei. So much to my great excitement, I went to Taiwan, and there I was honored and privileged, as were everybody else, to meet many of the luminaries of lifestyle medicine, as you can see in this picture, Dr. Hans Dale, Dr. John Kelly, Dr. George Guthrie, Wayne Dysinga, and many others. It was a wonderful conference that really opened my eyes to lifestyle medicine as a scientific field and the possibility that such a field can be actually started in India as well. So here are some pictures from this conference in Taiwan. We were physicians from all over the world and paramedics from all over the world. This is Dr. Lilac from Israel, Dr. Hansdack and myself from India, and Mr. Stephen Penman from Australia at one of the evening meals, which was, of course, whole food, plant-based. Those of us who met at this conference were obviously a group of like-minded, passionate physicians, all wanting to improve healthy longevity, not just the prolongation of disease to prolong life, but to improve healthy longevity using very simple lifestyle measures. Now, following this conference, there was another one in Manila in 2018 in the Philippines, February of 2018. And this was yet another very, very interesting conference with many, many luminaries again. And following this conference, over a meal, a few of us Indian physicians again got together to talk about actually starting this Indian Society of Lifestyle Medicine. And this was where ISLM was actually born. We established the Indian Society of Lifestyle Medicine by announcing it at the conference, and we also elected the office bearers at that point. And we went ahead to announce that Dr. Samuel Hansdag, George Samuel Hansdag, was the president. I took over as secretary at that point. The joint secretary was Dr. Jacqueline Michael, and the treasurer was Dr. Pramod. So the Indian Society of Lifestyle Medicine was established in 2018 and registered as a nonprofit organization in 2019. So we, as an organization, our hope was to encourage other physicians in India to join the society, to certify as lifestyle medicine physicians, and to go on to practice lifestyle medicine, either as a separate specialty or along with their specialty if they already had one. Following this establishment of the 2018 ISLM, we went on to have our first conference in 2018, end of 2018, that is 2018, December. Now, this was an in-person conference in those days when there was no COVID and we had the pleasure of meeting each other. This was in December in Bangalore. And at this conference, we had many, many luminaries from across the world talk to us about the various aspects of lifestyle medicine. Dr. George Guthrie, Dr. Mamtani, Dr. Wayne Dysinger, Michelle Palmer, and none other than Dr. Dean Ornish, Dr. Herb, and of course, Dr. Kaushik Reddy. So we had many of these speakers in person, and some of them were over Zoom, as we are doing right now. And we had very interesting panel discussions on diet and nutrition. We had breakout sessions. We also had several small group sessions where we practiced small meditative sessions as well as positive psychology and so on. Following this, we also had an experiential fitness session. And as you can see here, it was a bunch of very, very enthusiastic and exuberant delegates following the early morning session on fitness. Following this conference, 14, I think, 14 physicians sat for the IBLM exam in Bangalore. Now, this conference was a collaboration between ISLM and the Asian Society of Lifestyle Medicine, because at that point, when we had the conference, ISLM was not a registered organization, didn't have its own bank account, etc. So we went through the ASLM, and 14 physicians sat for the exam. Very proud to say that they all got through. This was the enthusiastic bunch of physicians following the conference. And subsequent to that, the second term of ISLM happened in September 2020, where I took over as president. The secretary was Dr. Anjali Nakra. Secretary is Dr. Anjali Nakra, joint secretary Dr. Rabani, the treasurer Dr. Ravi Modali. Now, in this, during the last 1 year, from September of last year to this year, 2021, we've had many, many milestones, which I'm extremely proud of. And the first one was the signing of the agreement between ISLM and the Lifestyle Medicine Global Alliance and IBLM. Now, it is after this agreement was signed that ISLM is actually able to have its own exam in India, and where we are a part of the global conglomerate of sister concerns of lifestyle medicine organizations all over the world. This was an extremely proud moment for us, and we hope to continue to work with LMGA and IBLM in this regard. We went on to nominate the board of advisors, which consists of some eminent physicians, both in India as well as out of India, Dr. Mohan, Dr. Makkar, Ms. Sheila Krishnaswamy, who is a nutrition dietitian, and more recently we've had Dr. Kadri, Dr. Sunil Shroff as part of our board of advisors. We look to them for advice on matters that we find that we need advice. Subsequently, we also went on to elect our board of directors, which is basically the working committee, which manages the various member interest groups, such as clinical practices. There are various aspects of lifestyle medicine, clinical practices, clinical services, health programs, memberships, membership alliance and advocacy, and so on and so forth. And so we have a group of board of directors, who are the members of ISLM, who have volunteered to. These are all, as you know, these are all honorary positions. Nobody is paid. So these are all enthusiastic physicians who have volunteered to be part of this board of directors. Now, they organize health programs. They align with different organizations and companies, establish these clinical practices, and so on. An organization, as we all know, can only be successful if the members get involved. It cannot actually be run by a couple of members of the executive board. So that's why we have this working committee, and working as a team, I believe that this organization can achieve great strides going forward. We've had various educational incentives, like a monthly webinar that goes on, which is open to everybody, and it's either based on registrations or it's also broadcast live on our ISLM website. Going forward, we also intend to have monthly journal club, which is for members only. We've had a steady growth in membership of ISLM, and now we are over 100 members, which doesn't seem very large at the moment, but I envision that this number will grow with the years to come. And I'm very excited to say that the membership is so varied across the board, from various specialties: gynecology, endocrinology, cardiology. We've got heads of departments of cardiology and various other fields from various universities. We've got new physicians, young physicians who have just passed out, even undergraduates interested, obviously, in the practice of lifestyle medicine. And I know that this membership is going to steadily grow, and one can become a member whether you are in India or outside of India. We've got several RP members who are also members of ISLM, like Dr. Murthy and Dr. Boja. And I hope that going forward, many more RP members will join us. Now, our conference, ISLM 2021, which we've just completed, I will talk about. The IBLM exam, which followed the conference, ISLM 2021. This year, I'm proud to say we had 32 physicians taking the exam, and this was a milestone moment. And I'm very excited that more and more physicians are actually choosing to take the exam. You don't necessarily have to take the exam if you want to practice lifestyle medicine, but it is strongly advised, because what the exam does is provide a certain structure for what it is that we are wanting to practice. We've now become a Tier 3 country through the LMGA, which means that we have many other benefits. And having our board exam here in India has, of course, many benefits, because you don't need to travel. For instance, when I took the exam, I had to travel to Edinburgh, because at that point, India didn't have the exam. And secondly, part of the exam fee that is paid by the exam candidates comes back to ISLM, and that, of course, as you know, is greatly helpful. So our conference ISLM 2021 was virtual, unfortunately, because on account of the pandemic, but it was a huge success and received very, very well by everybody who attended. We had over 700 registrations and from across the board, different specialties again, different fields of medicine. We had many, many eminent speakers, both in India as well as from abroad. And we had various talks on diabetes reversal. We had a wonderful panel on nutrition and nutrigenomics, talks on exercise, COVID and NCD, telemedicine, sleep, mental health, neurology, panel discussions on lifestyle medicine in pediatrics and the practice of lifestyle medicine. The keynote speaker was Dr. Ravi Mamtani, giving us an excellent keynote speech. We had a guest lecture by Ms. Preeta Reddy from Apollo Hospitals on the importance of lifestyle medicine and the relevance of ISLM as an organization. Dr. Kaushik, as usual, is also one of our speakers. We love to invite him every time because he's very much a part of our organization. So this was a huge success, and it happened on November 27th and 28th. I'm very happy to say that we were widely and warmly received. This is a panel discussion that we had on lifestyle medicine practices across various specialties and how it can be implemented in either in our own practice or as a separate practice. So going forward, ISLM has several visions which I would like to share with the audience. Obviously, we want to try and include a lifestyle medicine into general medical curriculum, either into the undergraduate or into the postgraduate medical curriculum. Now, for this, we need recognition from the NMC, which is the National Medical Council, which I'm told is not easy to come by, but we are working on it. And we hope that going forward, we can actually incorporate at least parts of it into the curriculum, maybe as a short course, because as you know, currently our medical curriculum does not really enable us or give us the tools to implement lifestyle measures or prescribe the evidence-based lifestyle measures into our practice. What we are taught is to treat symptomatically. What we are taught is to look at disease through the lens of symptoms and treat using diagnostics, using pharmacotherapy and pills and potions. Now, as a gynecologist, I'm not averse to pills and potions and procedures, not by any means. And I know it is absolutely essential, especially in emergency work. But what we do need is an addition to our armamentarium, because 80% of the world's diseases come from NCDs, and we need to be equipped to handle this 80% of disease. We also intend to work with the government because the current government is extremely supportive of so-called lifestyle medicine work and is encouraging the work of lifestyle medicine through other modes of medicine like the Ayush, which is appreciated. And there are protocols that are already available. There are lifestyle medicine clinics that are already established, which are currently being manned by other physicians. And we hope that by establishing lifestyle medicine and by establishing this connection with the government, we can actually become part of these already established organizations and already established clinics and so on. We would also like to, in this regard, actually, we've been approached by the IAPSM, which is the Indian Association of Preventive and Social Medicine, and it's a great honor to be approached by them. They would like us to collaborate with IAPSM to work in such lifestyle medicine clinics and other programs going forward. And this is a huge honor. We are working on this. We also want to align with universities, because that's where the young people are taught, and basic education on lifestyle medicine would, I think, go a long way and help us when we get into actual practice. The current alignment is with SRMC, which is the Sri Ramachandra Medical College in Chennai, with the Mind, Body and Lifestyle Sciences Department, where we would like to recognize the course that they are running on for health coaches, because lifestyle medicine is not is not an individual practice. The lifestyle medicine physician ideally collaborates with other allied health professionals like your health coach, a physiotherapist, an exercise physiologist, psychologist, dietitian, and so on, because the many things that a lifestyle medicine physician does cannot really be done by one single individual. So while the lifestyle medicine physician works within the confines of evidence-based medicine and is certainly not restricted to treating only symptoms, he focuses on the patient and the patient's family, keeping in mind the ideologies that the patient has, a certain mindset that the patient has, keeping in mind that the families, especially in our country, in India, are very much involved with the patient. So advice that you give the patient is often interpreted and is often conferred with the rest of the family. So many times the decisions to take certain steps towards health is not his or her own. So we work with the families. We recognize the upstream determinants of disease. We recognize the biopsychosocial aspects of disease. We implement several ways of treating the patient and managing the patient, including health coaching, positive psychology interventions, CBT. We may advise, for instance, intensive therapeutic lifestyle change. We may have shared medical appointments. So there are various ways of practicing lifestyle medicine. And for this, we do need a team. That is a more realistic approach to addressing lifestyle diseases. So for this, we also need to collaborate with other, not just the physicians, but other allied health professionals like your physiotherapists, health coaches, psychologists, etc. And all of these are people are also can also become members of ISLM, provided they have a recognizable degree as recognized by the Indian government. Now, we also are in talks with other universities like Manipal University, like Bombay University, and so on. And I hope that something comes of these talks. We would like to motivate and inspire young physicians, which is already happening. As I said, many young physicians become members, they call us, they message us saying that we would like to become ISLM members, we would like to take up the exam, and how do we go forward to practice lifestyle medicine and so on. And these are the protocols that need to be established, because I think the concern for many young physicians is that how do we practice lifestyle medicine in India? Because it's not yet an established field. It's not yet a so-called recognized degree. So what IBLM is offering as the diplomate is only an accreditation, and it's only academic learning. It's not yet an established degree in India. So that needs to be stressed because it's not yet been recognized by NMC. We would like to create strategic alliances, not just between other medical communities like universities and hospitals, etc., but also with interested individuals, with companies, and even with organizations like your social media organizations and so on. Because let's face it, today, social media is extremely popular, and it is of great concern to us physicians that there are so many myths that are being propagated through social media, which are not necessarily evidence-based. And we have many influencers with millions of followers who say things that are readily accepted by the people, by their followers. So instead of staying silent, I think it is our role as physicians to step forward and actually educate the public and the lay people as to what is really evidence-based and what are the strategies that they can use, simple lifestyle measures that they can use in their day-to-day life, both to prevent disease and also manage some of the chronic diseases, and in some cases, even reverse diseases. So it's our duty to do that as well. It's a social responsibility, is what I think. We also would like to include, say, senior physicians. Many senior physicians have started joining ISLM, and many of these physicians have already been using various aspects of lifestyle medicine in their practice by advising diet, for instance, by advising physical exercise and so on. We would like to include them into ISLM so that the patients are also encouraged to include lifestyle measures into their lives. Two, we would like to establish standardized education and protocol. And again, that is being done through the education department of ISLM, to the Director of Education and the team and her team in ISLM. We would like to amass more indigenous research, both from India and the Indian diaspora all over the world. And I think this is where members of RP perhaps can collaborate with members of ISLM and the research department of ISLM, research director of ISLM, to try and look at the Indian diaspora, because as we know, we have very specific genetic predictions for, let's say, early onset of diabetes, early onset of cardiac disease at the same BMI as our Caucasian counterparts. We have what we now term as the TOFI syndrome, which is thin on the outside and fat on the inside. We have a predilection for abdominal obesity. As an obstetrician, I'm very interested in DOHAD, or the developmental origins of health and disease, which states that disease actually begins in utero, when the mother is exposed to chemicals or nutritional deficiencies or hormonal disruptions and stress and so on and so forth. So we cannot really wait for disease, especially non-communicable disease, to actually be established and to actually present itself as symptoms, which can happen much later on in life. The actual process starts many decades beforehand, and that's what we need to put an end to by encouraging lifestyle change and lifestyle establishment as early in life as possible. We want to take more social responsibility by collaborating by local groups, local nonprofit organizations, which are already in the running, and lifestyle medicine physicians can very easily integrate into these organizations and help to help the behavioral change. So we know that it's not that we don't know that these lifestyle modifications will help. Most of us, I think, even the lay people for that matter, do know that it helps. We do know that a proper diet, we do know that soda is not good for us. We do know that eating ice cream every day is not good for us. We do know that smoking is not good for us. But the real problem is that behavioral change is not easy. And this is where the training that a lifestyle medicine physician receives in how to establish behavioral change, how to motivate the patient using motivational interviewing, using positive psychology interventions, using CBT, etc., how this can happen. And it doesn't happen overnight. It happens over a period of time. So this is the difference between a regular physician just sliding a prescription across the table and a lifestyle medicine physician actually holding hands with the patient and taking him through the entire process of behavioral change. So this is also where a lifestyle medicine physician actually changes from, or rather adds on to his physician hat, what is called as the hat of health coach. So we talk to the patient in a way that is not in an authoritative way where we are just advising, but also in a way that helps them to see the benefits of lifestyle change and help them see that sometimes behavioral change is not linear. You can have ups and downs, to support them through their plateau phase, to support them when they slide back to using their previous behavioral patterns and so on. So, of course, one of the most important things is to make India the forerunner to contend with globally in lifestyle medicine, which I think is possible given our population and given our population or the number of physicians that we have and our already existing passion for lifestyle medicine through our ancestry. So this is, for instance, some of the things that personally I've been doing, like village visits before COVID, of course. And these are the kind of things that lend very easily to lifestyle medicine, because advising patients about, advising lay people about diet, educating them about diet, and repeating the advice over and over again, helping them actually make that transition is what is required. I also work with Ashia, which is a school for children with special needs. And it's quite amazing how switching over from processed food, from sodas, from sugar, which was actually a practice in a school like this, can actually change the behavior of these children with special needs. And speaking to the teachers, who are quite amazing in their own right, speaking to them, even simple things like, for instance, they tell me that body odor from the children has decreased considerably after they have removed the processed food and sugar from the diet of these children. So I think we owe it to our future generations, and of course to ourselves as well, to implement these simple lifestyle measures into our own lives. In fact, lifestyle medicine is probably the only field that insists that the physician himself or herself actually participate and embrace the pillars of life, 6 pillars of lifestyle medicine to the best of his ability, his or her ability. So we owe it to ourselves to embrace this in order for us to lead healthy, purposeful, meaningful lives, both for ourselves and for future generations. And I'm quite confident that this is what is going to happen going forward. And I hope that this introduction to lifestyle medicine that all of you have been exposed to at API, thanks to Dr. Bernard, Dr. Kaushik, and then going forward, Dr. Murthy and Dr. Boja. I hope you will understand the sheer power of lifestyle medicine. And I hope that you will also join hands with us at ISLM to create this paradigm shift in healthcare that we are all hoping to achieve going forward. So the seed that was sown many years ago by those 5 physicians following the ACLM meeting has to be watered. And I think as a team and as passionate physicians wanting healthy longevity, this can be done. And this is my hope for this alliance between API and ISLM going forward. Thank you so much. And I hope that this is beneficial.
Thank you, Dr. Nambiar. This is Dr. Anil Tibrewal. I'm organizing the next session as well on lifestyle medicine. So wonderful speech and such a nice passion you have, and whole audience is very enlightened about your work you do. Any question from the audience? Any question? Okay, thank you again. I think we're happy to have you all. We start the next session now. Thank you, Dr. Nambiar.
Thank you, Dr. Sheila. Yeah, this is Boja again. Again, thanks for taking your time. And I know we were actually hoping to have Dr. Sheila in person, but because of the busy schedule, she couldn't make it. But again, thank you very much for sharing all that information about the ISLM. And then we're looking forward to actually advance in this path together, API and ISLM. Thank you very much.
Thank you.
Let's give a big round of applause, please. Thank you.
Good morning, everybody, again. So we're going to start our next session. It's a CME session, and I'm Dr. Anil Tibrewal. I'm a general surgeon from Dallas, Texas. I'm very passionate about lifestyle medicine and a lot of diseases that we can control and minimize the effect by changes in our lifestyle, including our healthy diet and exercise and various stress-reducing things. So we have 2 very impressive speakers today, and I'm going to introduce the first one, Dr. Boja K. Reddy, and the topic is Stop Mopping and Escape the Maze, Need and Urgency for a Paradigm Shift from Disease Care System to a Healthcare System through Lifestyle Medicine. Dr. Katipalli is a family physician. He has been with the University Health System and UT Health San Antonio, Texas. He's been practicing there for over past 15 years. He is an adjunct assistant clinical professor and served as a medical director for a busy multiplication ambulatory service line at the University of San Antonio, and recently board certified in lifestyle medicine as well. Inviting Dr. Bojake Reddy, Dr. Katipalli, please come over. Thank you. Your time is about, 45 minutes, but it will be helpful if we can cut down to maybe half an hour, 35 minutes. We're already running behind by at least 45 minutes, I think. So see what we can do. Thank you again.
Thank you, Dr. Anil. Yeah, I think there is a little bit of technical challenge. If y'all can give me just 1 minute.
Hello everybody. Sorry for the delay. I think there's some technical issue on the slideshow. So if you remember old time when we watch TV, suddenly the TV start working and we should say, interruption के लिए हमें खेद है, ऐसा कुछ said. So we should get starting very soon.
Guys, there's a technical glitch. They're restarting the computer and trying to kind of reboot the whole thing. But in the meantime, I'll be the last speaker about type 2 diabetes reversal. But if you guys have any questions about what was presented, lifestyle medicine related questions, I'd be happy to answer because I'm actually practicing it for the last 9 months to a year, literally in my office. Huh? So the question is, is rice advised or not, milk advised or not? So I'll give you, I don't know the studies done as far as rice is concerned, but they have done studies with oats. Okay? So in oats, I'm sure you all know oats, right? There is the whole oats as it comes from the plant. Then there is rolled oats. Then there is steel cut oats. Then there is oats, refined oats. Plus there is the instant oats. Okay? This is how things change from the oats to the instant oats. So I used to think eating instant oats every day was the best thing I've done in my life. But guess what? As you process the whole food, you have more inflammation. The high sensitive CRP they were talking was actually increased. So that is part of the reason why whole food is the right way. So here in rice context, they've polished it so much, everything is gone. And I want one thing to be very clear when you're practicing a plant-based whole food, whole grain diet, there's only one supplement you have to take. That's B12. If you don't eat dairy. That leads to this question about dairy, B12, vitamin B12. That's the only vitamin you have to supplement yourself. No, when you're eating plant-based whole food, whole grain. And so the next question is rice, right? Rice gets polished. And that's where the problem comes. It doesn't matter what you process and make it. The moment human beings touch it, disaster starts. And the reason why they do this to us, the more processed, is because evolutionary biology has clearly indicated 3 things that human beings cannot take that away from their daily lives. Fat, salt, sugar. All these big companies spend a lot of money in trying to process these to make sure that your brain is facilitating these 3 things. And that's why if you see any processed food, they have salt, they have sugar, they have fat. Because that's how human brain works. So your answer, dairy is inflammatory. Okay? So that's the reason and in United States, dairy is the second most common allergen. And I have a patient, I'm a family physician, wherein the patient had a lot of allergies and recurrent ear infections. And I used to give all the medications. After I learned lifestyle medicine, I asked I'm going to talk, but in my practice, I made 5 poisons first, and then I added recently 1 more. The first poison is processed foods. So what is processed food? Anything that's made in a plant is processed. Anything that's made with a plant in your kitchen is food. That's as simple as it can get. Number 2 is sugar. Sugar is the most inflammatory substance. And if you say, you can see the refined sugar. That's the white sugar. Brown sugar is also sugar. Again, it causes inflammation in the body. So the maximum you can get away from that will be advised. And the third is refined flours like maida, white rice, anything white, noodles, pizza, they're all refined products. Then animal products. So people question why animal products you can eat once a week, and then eggs. I'll give you a very scientific explanation. When you eat meat or eggs, they go into the gut, right? There is bacteria, right, in the gut. You all agree with that? So the bacteria turns the meat in the digestion process